Ladies and gentlemen, we'll begin in 5 minutes. Thank you very much, and please kindly turn your mobile phones into vibration or silence mode. Thank you. 提醒现场以及线上的贵宾，我们的大会呢，再过5分钟之后即将要正式开始了。现场的贵宾呢，也请您记得将手机转为震动或静音。非常谢谢您的配合。Ladies and gentlemen, we'll begin in 1 minute. Would you please take your seats right now? Thank you very much. 提醒各位贵宾，我们大会再过1分钟之后就要正式开始了，请您就座，谢谢。Ladies and gentlemen, good morning, good afternoon, or good evening, whatever time zones you are in. Welcome to the second day of 2022 Global Health and Welfare Forum in Taiwan， 非常欢迎现场以及线上的贵宾呢参加第2天的2022台湾全球健康福祉论坛哦。Yesterday in plenary session 1, we talked about how to bring people together to promote health and well-being for all. And today, this morning in plenary session 2, we'd like to talk about the technology and infrastructure that you might need behind these efforts. 那我们今天上午的主场2呢，要探讨的是健康福祉的基础建设以及相关的科技。And to moderate this session, we have the honor to invite our moderator, Dr. Meikwan Wang, Superintendent Emerita, 桃园长庚 Memorial Hospital, Taiwan, to join us. 接下来呢，我们就掌声欢迎我们的主持人，桃园长庚纪念医院黄伟娟荣誉院长为我们开场。
Good morning, honorable guests, ladies and gentlemen. Welcome to join the second plenary this morning. I'm Dr. Alice Wong, and it's my great honor and privilege to be moderator of this section. We have 4 speakers in this section. The first speaker is Mr. Michael Pearson, Branch Head, Office of International Affairs, Public Health Agenda Agency of Canada. He is responsible for health engagement at G20, G7, APEC, and also United Nations General Assembly and other multilateral fora. Mr. Pearson holds very much honors from University of Toronto, Calatento University of Ottawa, etc. Today, his topic is Canada's pandemic preparedness and response efforts, particularly related to the use of wastewater surveillance during the COVID-19 pandemic. As we all know, people infected with COVID-19 can shed the virus in their feces, even if they don't have symptoms. Therefore, wastewater data can be an important early warning sign for early prevention. The second speaker is Professor Indika Mahashi Karunatilaka from Sri Lanka, Professor, Department of Medical Education, Faculty of Medicine, University of Colombo, Secretary General, Asia Pacific Academic Consortium of Public Health. He's educated in to be the general practitioner in Sri Lanka and United Kingdom. He also holds many hours, such as President Hour for Research Publication and Public Health Middle of Merit. His topic is employing technology to combat COVID-19 in resources-constrained setting. As we know, Sri Lanka is a high-income country. Almost 100% immunization covered the whole country. During the COVID-19, they provide all patients who test positive were managed in the healthcare institute. And also the health workers besides of the urgent hospitalization, they facilitate home management and also telemedicine too. They will share the experience with us today. The third speaker will be Professor Jason Wong. Professor Jason Wong is the Director, Center for Policy, Outcome, and Prevention, also Professor of Pediatric and Health Policy, School of Medicine, Stanford University, United States. Professor Jason is a MD and PhD. He is majoring in pediatric, cognitive medicine, medical technology, IoT, and also AI. He's also worked for the Cancer Center in Taiwan and also the Dean by Curtis of the New School for Leadership of Healthcare based in Taipei. He holds many, many honors, such as from Harvard Medical School, Johns Hopkins, and also U.S. National Academy of Science, Medical, Engineering Committee, etc. His topic will be the new technologies and data system for pandemic surveillance and control. He will introduce the new detection technologies which can lead to improve the information, speed, convenience, and population-based snapshots for pandemic control of COVID-19 today. The fourth speaker will be Professor Rongxian Jiang, Distinguished Professor, Department of Computer Science and Information Engineering, National Cheng Kung University, Chair of Cheng Kung University Hospital IT Officer. He is the PhD in Department of Electronic Engineering and Computer Science, University of Missouri. He also hosts a lot of hours, such as Future Technology, National Innovation for COVID-19 Hackathon, and also Outstanding National ICT Elite Awards. His topic is a perfect AI solution, reducing health inequality and impact of COVID-19. He and his team create an AI pneumonia detector for COVID-19 pneumonia. This detection system named Medic Chest X. This is a very valuable and profitable product. But he is so generous and kind to open it for free use to many, many countries all over the world. Let us welcome the coming speech, the honorable speakers with our big hands. Thank you very much.
Thank you to our moderator, Dr. Wong, for introducing our speakers in this session. And now, ladies and gentlemen, please join me in welcoming the first speaker, Mr. Michael Pearson, Branch Head, Office of International Affairs, Public Health Agency of Canada. 让我们掌声欢迎第一位讲者，加拿大卫生部国际事务办公室 Michael Pearson 处长。Let's welcome him.
Good morning, everyone. Good morning, everyone. I noticed the time's up sign that was appearing there, so I'll try to be in my 20 minutes as much as possible. So you've already heard an introduction of who I am. I run this international shop for our Government of Canada, our Health Department. Among other things, we try to connect the dots, as we say, between our program leads and the policy that our ministers are advancing. What I want to talk about today is a little bit of what was advertised, but a little bit differently as well. I want to talk about the kind of connection between data, surveillance in particular, and public health decision making, and how you see the connection between those two. Those two are often the dynamics, the differences between those, or the challenges or tension between those in an emergency situation where public health decision making has to happen in a very rapid context, period of time, short period of time. And I'll use the Canadian example during the pandemic as a way of describing this dynamic of science and politics, because I think it's very instructive for all of us. We've all been through this in one way or another. We all know in the broader context that we've had, over 600 million COVID cases in the world, 6.5 million deaths, and 1.6 of those deaths have been in the Western Pacific. The United States, the #1 in deaths in the world, over 1 million people. What we're calling excess mortality. The top 5 deaths in the world: the United States, Brazil, India, Russia, and Mexico. And I mention this at the top because there is a correlation between the use of science or not use of science by the political level and the nature of that political level, whether it's an autocracy or it's a government that doesn't appreciate or support science. There is a correlation, I would argue, in the pandemic between the highest deaths that have happened in the world and those governments in those countries which did not actually think science was that important or relevant to the decision making that they were making. In Canada, we had 46,000 deaths out of 4.3 million cases. We were 26th in the world in the number of deaths, so we still had way too many. But I think, as you'll see, I think from our approach, we tried to link science and politics as much as we could in a way that supported the public health interests of our citizens. So the first case in Canada, January 2020, I'm not going to use, by the way, a number of, most of my presentation will be just me speaking. I do have a few graphs I'll show you. In late January 2020 was our first case in Canada. Our first death was 2 days before the WHO declared a public health emergency of international concern, March 11th, 2020, which, by the way, was also the date of birth of my eldest grandson. So he's forever known as the pandemic baby in our family. Government of Canada at that time immediately took a number of public health measures in that period, including the closing of borders, including the banning of non-essential travel. This is in the March period, and including sending everybody home to work remotely. And this is where the first element of politics came into play. We closed our borders even though we didn't really understand very well how the virus transmitted and moved from one part of the world to another. And we also told all Canadians who were living abroad at the time, other than our diplomats and others who couldn't go, and people working abroad, to come back to Canada in that March period. And there was a huge rush of Canadians coming home, many of whom brought the virus with them. So in fact, the worst wave of our pandemic, as far as the number of deaths are concerned, was in that early period, March, April, May of 2020, when we had a lot of infections that came into the country. So that was the first lesson learned about the relationship between science and politics. If you don't know what the science is telling you enough, you can make mistakes. And one of the mistakes we made was to, in fact, have that policy of bringing people home who actually brought the virus with them. We've moved quickly into what was called PCR testing. You're all familiar with that concept, what was still considered to be the gold standard of testing to determine from a data standpoint what is the nature of the virus, how much is it spreading, how many people have it. And this is, in our country, we were very decentralized when it comes to health. We have 10 provinces and 3 territories, so we have a national government that I'm part of, and then those 10 provinces and territories. And management of health of our publics are spread very much across those jurisdictions. And the challenges, this is where I would call the politics of number 2, is how PCR testing was done and eligibility for PCR testing. In that early period, in the spring of 2020, some provinces were saying you get a PCR test if you're symptomatic. Other provinces were saying, well, we're starting to see increasing evidence of asymptomatic coverage, or people who are not showing any signs of being sick but are sick or are infected. and we didn't really understand that well. I think it's commonly understood now that about 35%, 30 to 35% of COVID cases are asymptomatic in nature. And yet, because we had different provinces applying different measures, only test symptomatic people, others saying, well, we should test everybody who has been in a high-risk situation, whether they're symptomatic or not. We had different information, different data points that we were trying to apply in making decisions at that time. Again, emergency decisions about what public health measures to take, and that created inconsistencies from province to province, from part of our country to the other, about what degree of threat and risk we were addressing. Then we moved forward. After vaccines came online, so back into the early 2021, where we started applying PCR testing to borders. So this was a time when, with vaccines coming online in many countries, we were deciding to allow more travel to happen, but at the same time we were insisting on PCR testing at the borders, trying to learn the lesson that a way to gauge the level of risk in border travel or traveling across borders into Canada, out of Canada, was to do this testing, particularly inward travel, testing and quarantine, which I think everybody's familiar with with various views and experiences about it. That was in early February 2020. It was in early 2021. Then we moved in late in that year to another data point, which was rapid antigen testing, or RATS as we call it. This was linked to the outbreak of Omicron, as many of you remember, from the late fall of 2021, when Omicron sort of took over and case counts skyrocketed in Canada, as they did in many parts of the world, and PCR testing couldn't keep up with that. So we had to move to rapid antigen testing as a way to try to measure the degree of risk with not just cross-border travel, but essentially in our communities more generally. And this is where, again, politics came into play. We had the federal government responsible in Canada for the procurement and distribution of these tests, but provinces and territories who are responsible for ensuring that that Canadians got access to these tests. And again, it wasn't even from one province to another, depending on where you lived in the country, depending on whether you could get access to tests, on whether you would get them for free or you had to pay for them. And that was, again, another thing where we were trying to use a new data point, a new way of measuring using these RAT tests at the same time as not having a coordinated approach to being able to get the information for the purposes of assessing risk in the future. So finally, then we led from that, in the recognition of that reality, that we couldn't get this information, and many people, even when they were testing themselves with rapid antigen tests, just like all of you did when you came into the country, for those of you that came in for the purposes of this event and were given your kit at the border, we found that people weren't reporting on those tests. So we had no real evidence of the degree of risk. So we started to move to another data point for measurement, which was rate of hospitalizations and deaths. Because it was that rate that was able to give us a sense, a more accurate sense, of how serious Omicron was, or how much infections were leading to hospitalizations and deaths, and therefore what was the higher risk factor for our society as a whole. Connected to that data point of using hospitalization and deaths was wastewater surveillance. So this is something that we started in actually the fall of 2020. It was the agency that I work with. Started doing this in five cities across Canada. And we started this, I said, in the fall of 2020. Nobody paid attention to that at the time, but it turned out to be hugely important. For anybody that's wondering what is wastewater surveillance, I will try to describe it in a very simple way. It's basically measuring your poop. Anytime you flush the toilet and it goes into the wastewater system, you measure, take measurements from that wastewater in a city, a neighborhood, whatever, and you're able to determine the degree to which that a coronavirus existed in the wastewater. So you see with this chart here that we have developed now across Canada over 60% coverage of our population with these wastewater sites across every province and territory there, for the purposes of being able to, again, this has become the most important data for the purposes of determining what public health measures need to be, and not just for decision makers, but also for the public. And I want to emphasize that because the public's awareness and knowledge about wastewater surveillance has itself an important impact on how the public reacts to public health measures, or indeed takes on certain measures itself to protect individuals. And I'll come back to that in a minute. So not only does this wastewater tell us what the detection of the level of virus is, it also, there's a link between that information, and we'll move to the next graph, Carly. That gives us, so here we have the city of Ottawa, where I live, the capital of Canada. And as you see, this is over a period of time from September, so back at the beginning of the chart, that's I think 2001. And this moving on, where you see the waves, the various basic waves, that's what this is what the testing was telling us, the wastewater testing was telling us about the degree of virus that seemed to exist in the community. In this case, a city of 1 million people, the city of Ottawa. And you see how those up and down, the different waves, to the very end on the right here where it seems to be going down. This is information that's available to the public. Anybody can see this. And anybody can make a decision on the basis, so not just decision makers, not just public health decision makers, but the public itself can make decisions and do make decisions about what measures to take, including masks, for example, on the basis of seeing this chart. So there's a second chart, Carla, if you can show that one now, also from the city of Ottawa. Again, those same waves that you saw before, except what you're also seeing here is the degree of the black line at the bottom, the degree of hospitalizations, not deaths, but in an ICU, intensive care unit. And again, it gives you a very interesting contrast between the degree of infection that may exist in the society at a time and the actual high risk factors of hospitalization and deaths, which from the standpoint of health system resilience, it's all about trying to ensure that hospitalizations and intensive care unit usage is as low as possible. And again, linked with wastewater surveillance, we were able to determine in the context of these various waves what that was telling us about the relative risk factors for decision makers and for the public to think about in the context of when they went out and about what they did and how they protected or decided not to protect themselves. These two together, as I say, give you a very effective risk assessment. So that evolution from PCR testing to rapid testing to then this wastewater surveillance, especially when rapid testing is not reported in any significant way, a way of being able to give decision makers and the public a sense of what the risk factor is. And by the way, wastewater surveillance is not only good for testing for coronavirus, it's been proven to be good for detecting monkeypox, polio, TB, flu, and antimicrobial resistance is going to be a longer term challenge many of you are familiar with that we can use wastewater surveillance for the purposes of identifying the level of risk in our society. So I want to link that to the next graph now, Carly. I want to link that to the monitoring of variants of concern. So as you can see here, just again, moving chronologically from the end of 2021 to the present time, the different kind of how wastewater was detecting the degree of different variants of concern and subvariants of concern that were in Canada. This was based on Toronto, our largest city in Canada, but it gives you a good indication of how that information was giving us a good sense of which variant was having the most likely impact. Again, this is in the absence of PCR testing, which was always telling you not just whether you were infected or not, but what variant you had, whereas rapid tests don't give you that information. They only tell you whether you're infected or not. This was giving us information of what kind of variant was having the most likely impact and effect on Canadians over time, right up until the present day. So this, again, is a very useful way of being able to monitor the degree to which any particular variant is a significant player in society. And you link that to, the earlier information that I was showing you on wastewater surveillance more generally, and the waves or the hospitalizations and deaths, or ICUs, and that gives you a much more comprehensive picture of what the relative risk is. And on that basis, we were able to make more intelligent decision making. But this is, remember, this is like two and a half years into the pandemic. I mean, it started a year and a half, more than a year and a half, almost 2 years into the pandemic, and now up to the present day. So it took that long a time for us to develop this level of sophistication of analysis to get that information. Now, I make that point because we have a lot of lessons learned in that that we need to be thinking about in that context. One of them relates to vaccination. So the last graph, Carly, on that one. So these are just a G7 comparison, Canada at the top there. We had 82% take-up, the blue, of primary series. We've only had 50% take-up of anyone taking a third or fourth dose. And the comparison, very good on the first two doses, so good public health compliance, Good public compliance with public health measures, in particular vaccination in this context, went down to has gone down to 50%, where you have other countries which are higher in that regard, except our good friends from the United States. And what's happening in Canada now is that we are linking the evidence that we're getting from wastewater surveillance and the degree of which, and the current variants of concern, the Omicron variants of concern, BA4 and 5, and we're using that information to tell the public to get their booster shots, to get 3 or 4, get their third dose or their fourth dose, and eligibility goes right down to 6 months old now for Canadians. And we'll see this 50% figure go up as a result. And I mention that because there's that connection we make between, again, the evidence that we have, the science that we have, and data that we have, and the public health risk communications, as we say. We talk to tell the public, this is why you need to get a booster. This is why the evidence is clear that in order to protect yourself, not from infection, by the way, and we've always tried to make that clear, it's not, vaccines don't prevent, COVID vaccines don't prevent infection. What they prevent is hospitalizations and deaths. And that is the key distinction that we make. Eventually, as my Chief Public Health Officer talked to Tony Fauci about just a few weeks ago, we want to have vaccines invented that actually prevent infections, not just hospitalizations and deaths, for all good reasons. But in this case, at this situation, with the current crop of vaccines that we have, the idea is to make people see that connection between access and having vaccines and keeping themselves immune as much as possible, or at least protected against hospitalization and death. Now finally, lessons learned we're using about that. By the way, this booster campaign was where politics was good. It's across Canada. Every province and territory is an advocate of this approach. We all are back on the same page, but we're not on the same page when it comes to mask wearing. What's so interesting is that while you have the same public health officials at government levels saying, get your booster, those same public health officials, by the way, this is all provincial and territorial because they're in charge of public health measures at the local level, they say, no, you don't need to wear a mask. And I know there's a live debate in Taiwan now about mask wearing and whether it's useful or it's not useful and in what context. And what I think is happening in Canada, and you may have the same debate here, is how do you move from sort of government telling you what to do and what measures to take, and you making a personal decision about what is in your best health interest. And you know, there's always there's a lot of tension in that dynamic, but that is where we've come in Canada, and you see that whether it's people in grocery stores or it's people walking down the street or whatever, the degree to which people wear masks is really related, we find, in part of not just a personal choice, but we call it an informed personal choice. All this information of wastewater surveillance and the connection of these various data points are about making sure the public, when they make that individual decision, are doing it on the basis of as being as well informed as possible. And I think that is we'll see over time, but that seems to be a good way of being able to try to keep public trust. And I want to emphasize this as my one of my concluding points, is that maintaining public trust over time in a public health emergency is critical. Because if you lose that trust over time, they're not going to listen to advice and comments that are made by government or other sources about what public health measures to take if they don't trust you. If they don't think that or they think you've been leading you down the garden path in the time up to that. And again, that depends on politics, it depends on what part of the country you're in, but the maintenance of public trust from a public health official standpoint is critical, and the use of data to support that trust is equally critical. Two other comments I want to make about what we've learned about building and what works, and this could be applicable in Taiwan, it could be applicable, frankly, around the world. Proper planning, obviously pandemic planning and response. And part of that is having personal protective equipment, including masks and other things, in abundance. So we don't have that sort of have and have not approach, which we saw with PPE at first, and then we also saw with vaccines later. Regional biomanufacturing, trying to develop. We didn't have a domestic biomanufacturing vaccine production capacity at all in Canada at the beginning of the pandemic. We were reliant on other countries, other places where we were purchasing vaccines to be able to get those vaccines to Canada, and that was sometimes successful. It wasn't always successful, and of course, as we know, a number of parts of the world never had access to vaccines at all, or very few. So one of the lessons being learned, and it's being discussed in G7 and G20 and other venues, is build up that regional biomanufacturing capacity, not just for vaccine production, but for medical countermeasures more generally, diagnostics, treatments, whether it's PCR, whether it's antigen, et cetera. Make sure you don't have that situation in the future where there's a big supply and demand disconnect. And then finally, prioritizing populations. In Canada, we have a lot of Indigenous and remote populations, older people in long-term care homes. That's where the highest deaths happened early in the pandemic. In the production of vaccines and distribution of vaccines, we prioritize those populations that are most vulnerable. And I think that's the same in any society, where you need to be thinking about where the populations are that are most likely at risk and making sure that they are prioritized for access to medical countermeasures that minimize the risk to them. And then use risk communications, as I'm saying, to promote all that, not just promoting the evidence, the true evidence, but to combat disinformation at the same time. A huge challenge, not just in Canada, but globally, the amount of disinformation on social media about vaccines and their efficacy and safety, etc. That's one element, build on what works. Global cooperation, WHO, and its COVAX system, I think a large experiment, sometimes successful, sometimes not, but a very important experiment about how you move to broader, beyond regional biomanufacturing to global distribution of vaccines to make sure that everybody has access. Regional collaboration. So Canada and Taiwan have worked very closely in APEC as two member APEC economies on using that venue and that forum to, again, collaborate on issues of health that can be of benefit to both of our societies. And sustainable financing. This will be the key consideration, is whether or not the international community is going to put enough money behind the kinds of issues, planning, regional biomanufacturing, prioritizing population, putting enough resources behind that to make it effective. And then I want to say one last thing, is also you learn from others. And I want to highlight in that context Taiwan's National Health Command Center. You know, coordinated response, rapid deployment of personnel and medical countermeasures, effective surveillance, risk assessment, and risk communication. These are all things that I understand the Command Center has been focusing on. These are all good things. These are all important things, and things that we should be thinking about in all our societies, of having that coordinated approach. No matter how, whether you have a central jurisdiction like exists here in Taiwan, or you have a very decentralized health administration system like exists in Canada, that coordination, that command center approach, that coordinated approach of talking to each other and working collectively with each other, all of those things will make a huge difference when it comes to maintaining public trust. So that's it for me.
Thank you so much to Mr. Michael Pearson from the Public Health Agency, Canada. 非常谢谢我们第一位讲师哦。And if you have any questions, we have a 15-minute Q&A at the very end, so you can save your questions till the very end. Thank you so much. 那么最后呢，还有15分钟的 Q&A 时间。And now we'd like to welcome our second speaker this morning. Ladies and gentlemen, we are very honored to be joined by Professor of Department of Medical Education, Faculty of Medicine, University of Colombo, Sri Lanka, Professor Indika Mahesh Karunathalake. Ladies and gentlemen, please welcome Professor Karunathalake. Yes, he's online with us right now. 接下来呢，我们就有请斯里兰卡科伦坡大学医学院医学教育系的教授。Yes.
Good morning. Can I share my screen?
Yes, please share your screen. 好，让教授稍微作业一下这个时间哦。那就像刚才所提到的 ，and we have 2 more talks after Professor Karunathalake's talk, and we have a 15-minute Q&A. So feel free to raise your questions either by raising your hand at the very end, or you can leave your questions or comments online. 那最后呢，这个15分钟的 Q&A 哦，大家届时都可以举手提问，或者是 我们线上呢也有很多与会的朋友们，都可以在线上留言或者是留下你的问题。Yes, we can see your screen right now. Would you please make it full screen?
Is the screen visible now to all of you?
Maybe it's better if you can enlarge it a little bit more.
It is made full screen at the moment.
No, but it's okay. Professor, you can go ahead with your talk.
Is the full screen visible to you?
No, it's not yet full screen.
Okay, shall I try it again?
Yeah, you can try it again. Yeah, so that we can see your slides more clearly. Yeah, I think on the bottom on the right, yes, you can adjust the percentage, right? It says it's 78%, maybe you can make it 100%. Yeah, technology. So that's why we would like to talk about technology and infrastructure this morning. Yes, all right, it happens. No worries. 我们让教授再试一下，看一下能不能全荧幕。等一下，如果没办法的话，我们就先让教授讲好了，这样时间的关系。Professor, are you ready to go?
Yes, I'm trying to share the full screen with me.
All right, and after 4 talks this morning and in the afternoon, it will be the parallel session. Yes, we can see your screen right now, but not yet in full screen.
Yeah, is it like a part of the screen?
You see that there is a bar on the bottom on the right. It says 78%. Maybe you can make it 100. If it still doesn't work, it's okay. Just go ahead with the talk for the concern of the time.
Let's go ahead with the talk, I think.
Yes, please.
Yes, I think that's better, yes.
Yes, Professor, please.
For this very important session, I would like to thank the organizers of the Global Health and Welfare Forum in Taiwan for inviting me to join this very important conference and the convention. And again, at the very outset, I would like to apologize from all of you for not being able to be in with you. A visit that I was very much looking forward to make, but unfortunately and ironically, the reason being that just before the visit, I was found to be tested positive for COVID-19, so somewhat ironically related topic that I'm going to talk about. So during this morning, I'll be discussing about employing technology to combat COVID-19 in a resource-constrained setting. And greetings from Sri Lanka. Again, a beautiful country, a beautiful island nation, very much like Taiwan, with a lot of natural beauty. And there are some similarities between Taiwan and Sri Lanka. Sri Lanka being an island nation, about maybe 2 times like Taiwan, but the population is same, and multicultural, multi-ethnic, multi-religious country. And the capital city is Colombo, a cosmopolitan city, but not as much as Taiwan. And we also have a very beautiful central mountain region like you do have in Taiwan, a very beautiful country. And most of the country are rural areas. And as you may be knowing, at the moment, the country is going through a very turmoil, kind of catastrophic political and financial situation, economic situation. Previously, Sri Lanka was upper middle income country, but due to mismanagement of fiscal policies, so on and so forth, at the moment, the country is undergoing financial crisis, economic crisis, and becoming a low-income country. Maybe this image might show, might illustrate the mismanagement foreign loans on maybe mega constructions. What you see in the background is said to be the tallest tower in Southeast Asia. At the same time, there are trishaws and taxis fueling, queuing up for fuel, and there are a lot of difficulties that people had to face, and which has led to a lot of political unrest and ultimately leading to the change of president, and president has to leave the country. So it's kind of a catastrophic situation. At the moment, the political turmoil is somewhat over, but the financial situation is there. So I am making my presentation in this background. If you take the country profile of Sri Lanka...
Professor, sorry to interrupt. Please also make sure that you are moving the slides along because it's the very first page that we see here on the screen.
Okay, you can't see the slides now?
No, it's still the first page.
Still the first
Yes,
page?
yes. Now it's the country profile. Yes, yes.
Okay, now you can see, no?
Yes, health system.
Yes, okay. Okay, if you take the health system of the country, it's this is a very strong health system related to the curative sector with very strong public and private sector and very strong emphasis on preventive sector. Actually, Sri Lanka is taken as an example with a low-income country having strong emphasis on the preventive sector and achieved many health indices related to that. For example, with the strong emphasis on the preventive sector, the achievements were very much known, very well known, and very much recognized worldwide. However, the COVID-19 has faced a different challenge, and a challenge that the world has never seen. So it was a challenge for our country as well. Yeah. So this graph shows Sri Lanka's COVID situation in a nutshell. I assume you can see the slide now.
No, it's still a health system on the.
Okay, sorry about the. I might think
Yes,
I might have
yes,
to go back.
I can see the graph right now.
Yes, you can see the graph right now. I might have to go back like this. Okay, now you can see the graph right now. So I'll maybe switch in between these modes and then making the presentation. Okay, this shows the COVID situation, COVID control situation in Sri Lanka, and basically you can see the initial phase was very much under control. Sri Lanka was very much under control in the initial phase. In the early 2020, the number of patients were very limited. You can see initial part, the number of patients are very limited, and later only it has picked up. And towards the latter part of 2020, there was some pickup, but again, not much compared to other countries, maybe 200, 300 patients per day. And then towards 2020, middle part of 2020, there was a huge crisis with the Delta variant coming up. My presentation is mainly based on this presentation, mainly based on this. So, Sri Lanka's COVID-19 response is characterized by a very strong focus on preventive aspect. And at the very beginning, there was sort of contact tracing and quarantine. It was very strict, like in Taiwan, and isolation of patients was there, and every patient who was tested positive was isolated. The technology was used to the maximum extent, using the GIS technology and so on and so forth, and also the mobile technologies. Contact tracing was made, and quarantine policies are very strong during that time period. Even though the resources are limited, there was very rational use of available resources. With all this, the initial phase, Sri Lanka had very strong control on COVID-19. And Sri Lanka Medical Association, the country's national medical association, which I was the president, has played a leading role during this time period. Even before the first patient was detected for COVID-19, we had our first national seminar on COVID-19 in January 2020. During that time period, we didn't have much understanding or knowledge about COVID-19. Therefore, during that national seminar, we learned a lot about the situation, and then based on that, there were a lot of policies that were made related to COVID-19. You can see a lot of enthusiasm and a lot of participation during that national meeting that we had initially. And after that, there were a lot of activities that were held. And for example, in March 2020, there was an international webinar. First time we have conducted hybrid webinar on COVID-19 to the Asia Pacific Academic Consortium for Public Health, with a lot of resource persons from APAC region coming together and discussing how to face the pandemic. And thereafter, so many public health education activities have taken place, use of social media and mass media to educate public, and several activities. Now, in this slide, you can see the Director General of Health Services, again, taking part in several health education campaigns. So a lot of activities have taken place during that time period. Similarly, we had a lot of focus on vaccination, and the initial vaccination was 80% coverage, but later it has gone down. So you can see during the initial phase, we had a lot of good control. And towards 2020, end of 2020, we had the APAC conference in totally virtual mode in Sri Lanka. Again, use of technology, because that was the first hybrid APAC conference with all the resource persons coming together and discussing and about COVID-19, and the APEC declaration too was made during the conference. However, as time went on, the emphasis has gone down. It happens. In 2020, there was a decline in public interest, and there was a lot of, say, disinterest legislation were relaxed, and there was a relaxation about the public safety measures. So what happened was something unprecedented towards the middle of 2020, because during that time period, something unexpected happened. As I have mentioned previously. The number of COVID patients have increased rapidly. Previously, as I have mentioned, it was around 203,300, but towards the middle part of the 2021, the number of patients have increased so much. It has gone up to, officially the figures has gone up to 2,000, 3,000 patients per day during this time period. But in actual figures, it might have been estimated up to 9,000. So it was a very catastrophic situation that were faced in this time period. The hospital capacity was going beyond the capacity. The hospitals were overflowing, and it was not anymore possible to admit all the patients who were tested positive with COVID-19. And also similarly, the ICUs are being filled up, and then there was a difficulty to cater for the patients who are really needed. So that due to that problem, a lot of patients were dying because the hospital system was overflowing with thousands and thousands of patients. At the same time, it was very difficult to identify the patients who were needed. And this was a very common sight during that time period, where the ambulances were rushing in to take patients in all the cities. So it was a very catastrophic and very unfortunate crisis situation that Sri Lanka health system was facing, and the number of deaths are soaring, and about 200, 300 deaths per day. So it was a catastrophic situation. There was an immediate need to prioritize and identify those who need the immediate care and the immediate help. So that was the priority that during that time period. And during that time period, there was some available patient helpline services. For example, Sri Lanka Medical Association had a 24-hour hotline service that was available. So then all the stakeholders got together and then decided to come out with an innovative mechanism to basically identify those who are in need. So therefore, the Ministry of Health, Sri Lanka Medical Association, World Health Organization, and the National Center for COVID-19 all got together, and they developed a mechanism, telemedicine mechanism, with the very limited resources that were available, to identify those who are in need and to provide immediate treatment for them. And then we have developed a protocol that was required. Basically, it was similar to this. Patients who are COVID positive or who are having symptoms, they have several options. One is to call the emergency hotline if they are having severe difficulty in breathing, and they will be taken immediately to the hospital through the National Ambulance Service. Or if they are mild symptoms, they can call what I mentioned as 247 hotline, which is available 24/7. And then there will be doctors available in this hotline service 24 hours, 7 days, and they will be answering the calls. And based on few simple questions like the symptoms and the vaccination, whether they have difficulty in breathing or chest pain, then they will be triaged. They will be selected. They will be decided whether they can stay at home and isolated, or they need immediate admission. Then there will be another SMS system that will be activated, and ambulance will be sent to their home, and the patient will be admitted to the relevant center. some patients who can't call, they can SMS to hotline number 1904, and that SMS will be sent direct to the National Operations Center, and the doctor will be calling back to them. Again, based on few simple questions, they will be triaged, and again, decisions will be taken. And if they are in a serious situation, again, ambulance will be sent to transfer them to the relevant place. So again, this algorithm explains it. Either they can call 247 and the call will be taken, and based on their situation, either they will be transferred immediately, or they will be admitted later, or they will be advised according to their symptoms. Or they can SMS where they will be called back, and again, ambulance will be sent if they are in urgent crisis situation, or they will be given advice. And this system has worked beautifully. And this photograph is taken from the National Operations Center during that time period, where the dashboard gives the immediate information regarding SMS that are coming. And there are doctors and medical students who are working 24 hours there answering calls. So this was the system that we have been following. And there was a GIS system that to follow all the patients that were there. So the initial response was actually, there were a lot of calls coming, thousands and thousands of calls coming in the initial few days. But as the system was establishing, the number of calls was coming down, indication of the number of emergency patients are also coming down, and the situation is getting under control. And again, you can see initially there were a lot of ambulance calls coming, because we detected a lot of immediate urgent patients who were in need, and then they were transferred, and after they were taken to care. Again, you can see as time went on, the situation became under control. And this was given a lot of publicity in mass media and the national media, and there were a lot of journal publications also. And based on this experience, we have published a patient management companion based on simple principles of pathophysiology. We highlighted very simple areas because our country is resource constrained. We highlighted the importance of proper resting, proper positioning, proper hydration, and immediate admission if you have serious symptoms like difficulty in breathing. So the management principles are based on very simple situations, but the results were spectacular. And there was statistical analysis done, and it has shown within very short time, the situation became under control, the number of deaths have gone down, and the ICU beds now become more available, then the oxygen dependency has become less, and now this is a situation. Now you can see the situation going under control. Later it had picked up a little bit more because of the Omicron, but currently there aren't many patients. And actually, at the moment, I am also getting support from the same network that I have established. And in a way, this was there was a lot of learning experience from the situation that I have also faced, because the contact tracing showed that the contact was from an unimmunized individual who was not following the mask. At the moment, the mask wearing is not compulsory. This shows one thing, that unless everyone is safe, no one is safe. So I think immunization is very important. That also gives a very clear message. In conclusion, the message that I want to give based on our experiences, even in resource-constrained settings, technology to benefit health system can be implemented even at resource-constrained setting, and commitment, collaboration, coordination is the key to optimal utilization of resource and technology. Thank you very much. 谢谢.
Thank you so much to Professor Karunasilake joining us from Sri Lanka, and please join us later for the QA. All right. Now let's welcome our next speaker, Dr. Jason Wong. He is the Director for Center for Policy Outcomes and Prevention and Professor on Pediatrics and Health Policy, School of Medicine, Stanford University. 接下来让我们掌声欢迎史丹佛大学医疗预防及成果政策研究中心主任王志宏教授，掌声欢迎。Let's welcome him.
Good morning. Thank you for attending today's conference, and I want to thank the organizers for inviting me. So today I'm going to talk about new technologies and data systems for pandemic surveillance and control. So I have 3 topics today, and we'll see if we could get through all of them. The first one is contact tracing and quarantine technology. And this is particularly important at the beginning phase of the pandemic, where a lot of countries are trying to do border control, and this is prior to the vaccines were available. So, as you know, for every country dealing with COVID, there are various data streams needed to support the pandemic response. So for border control, for example, for Taiwan, there's the TOCC, the travel history, occupation, contacts, and clusters that people needed to fill out when they enter the country. Taiwan has 1 port of entry, the Taoyuan International Airport. But for example, in the United States, there's 300 ports of entry, okay? And so it becomes very obvious that when you have 300 ports of entry, it's very different than when you have 1 port of entry. And people will come in on air, cruises, and sometimes across the border by land, on land. And so there's a very complex problem here, and I'm sure a lot of countries here are dealing with the same issue. Now, the public health data in the central and the local government needed for contact tracing are from different places. For example, the symptoms data collected in the workplace and school, the medical records collected at doctor's office and hospitals, and the laboratory data. Sometimes labs are separate, so you need to integrate that data so that the decision makers, the doctors, the public health officers will be able to integrate all of that. And then there's the data needed to manage the healthcare system capacity and assets. And so many of you have dealt with the availability of hospital rooms, particularly in the ICU, the respirators, and also healthcare personnel. You need to know who's going to be on call when in the hospital. And then dealing with PPEs, the availability of masks, gloves, shields, clothing for healthcare workers. And finally, the testing capacity, the PCRs, the rapid antigen test. Anytime you have a crack in any of these data systems, it's hard to make a decision to mount an effective response. And that's why data is very important. And the challenges of data gathering and integration are numerous. Starting with trust of people who want to give you data, that there are symptoms. Some people are uncomfortable having governments or private sector collect all these data. So you need to get them to participate. The timeliness of data integration to make a decision. For example, if you get your test back in a week, it's useless, okay? To get a PCR back in a week, that's useless. And also the interoperability of data systems. A lot of the data systems are still under the CCDA format. The most recent FHIR standards are now being sort of gradually adapted in the United States and elsewhere. And so this will lead to greater interoperability of data, information and data transfer. When data from mobile phones, from different medical records, from labs could be integrated through the FHIR network, allowing for timely analysis and decision-making. Now, lastly, there's laws and jurisdictions that's needed. So for countries to collaborate with each other, you need to have trust. And so, if I'm telling you the data about a passenger, you need to trust that my data is correct and mount an effective response. There are often confusing laws and jurisdictions just within a country, within states and provinces, as Mr. Pearson had pointed out in Canada. And we have a lot of that in the United States. And ethical issues of using the data is a big problem. So during the pandemic, in the year 2020, Taiwan had actually mounted an incredible response. By March of 2020, all the data were integrated. In fact, by end of January, the immigration data were linked to the National Health Insurance database, so that a doctor could be alerted at the point of care about the person's travel history if they've been to outside of the country in the last 14 days. And that allows a different sort of alert for healthcare workers to put on the PPEs to make sure that they screen for the symptoms. So that is no easy task, as all of us have dealt with that. Now, there are new epidemiology tools from digital tools from consumer technology. All of us probably all have cell phones. With that, there's the GPS capability, but also sort of just the signals, the wireless signals capability. Wearables, such as Bluetooth that you connect to, listen to music with your earpiece. Video surveillance are used in some countries, social media. QR codes, sometimes people ask you to do a QR code when you enter a shop so they could know where a person has been. Crowdsourcing, internet searches and news. If a lot of people are searching for cold medicines, that's probably a hotspot somewhere. And pharmacy sales of cold medications. So there are ethical considerations. Sometimes in the beginning of the pandemic, when there are no cures and it's a deadly disease spreading fast, and there are no vaccines, then it's kind of unethical not to use the technology, but you have to put a limit on it. You have to say, how long can you keep the data? Is that going to be mandatory or voluntary, right? So after you get past the ethical consideration, sort of, is that ethically justifiable? But is that ethically obligatory, right? When a disease severity is very, very high. So after you move into sort of the early border control stage where, you can't contain the virus anymore at the border because it's now in a community, a new type of technology has emerged using the Google Apple exposure notification, right? And this is a Bluetooth technology where if your phone is very close to another person's phone for 10 minutes, they will shake hands, and that will create a signal, and it could go up to a server where it says, 2 phones have shaken hands, okay? And what this allows one to do is that it allows one to know if you've been seeing somebody next to the metro, and they have COVID, and if they volunteer that information, then you will know you've been exposed at the metro. Usually these are people that you don't know. They're not your friends. They're not going to be able to get from contact tracing because you don't know who's sitting next to you in the metro. So this has been implemented in the UK, particularly in England and Wales. This is a Nature paper where they have shown that 50% of eligible individuals participated in the program. Among the 50%, 70% will volunteer their information to the NHS, the National Health Service, if they got COVID. So this is a crucial piece where you have to volunteer. Okay, so to give people a sense that it's voluntary. I'm doing a good deed. Okay, 70% of people did that. So what they show is that for every 1% increase in the adoption, there's a 1% decrease in cases. That's pretty incredible. Okay. Now, if you look at sort of the ethical concerns and how long these are used, for example, in China, it's mandatory, central surveillance. They also use facial recognition and social scoring. The National Health Code System basically allows one to either move or not from one location to another. So that is the most restrictive. Okay, Israel is doing something very similar. It's GPS-based. It's actually run by the Secret Service, supervised by Parliament and the Supreme Court. So at least it has an oversight in Israel. It's supervised by the Parliament and the Supreme Court. I don't think China is supervised by anyone except the government. In Taiwan, it is also centrally mandated surveillance through a Communicable Disease Control Act that was passed as a legislation, and you could activate that law. So the government has special powers during the pandemic. Initially, it was GPS-based, but then it's changed to cellular signals. And then Taiwan also added QR codes for location tracking. In France, Australia, and New Zealand, it's voluntary apps. The centralized model is using Bluetooth. Italy, UK, Germany, Switzerland, and Australia, voluntary apps is decentralized model using Bluetooth. Okay, so I told you these ethical issues that are raised. In the United States, we can't really track people except for law enforcement. Okay, so data are not ordinarily used for tracking down individuals, particularly if you're going to impose consequences like quarantine. That's a consequence. Okay, equity concerns and also autonomy. In the United States, you have to ask for permission to access personal information. That includes informed consent. Contact tracing through cellular records, it could be an opt-in or an opt-out. or if you want to ask for consent. Equity concerns, sometimes the data is not evenly distributed, but with cell phones, I think it's now pretty ubiquitous. Most people have cell phone. So it's actually decreasing disparities of reaching people, but you have to make sure your data is representative of the population. If to minimize the risk of error, if you make a mistake, you need to have a correction mechanism. So you just can't tell people you can't move anymore because the system made a mistake, right? What if the person says, I've never been anywhere, but then it's turning red? So that's the other thing. So the new technologies that are now emerging as a result of the COVID pandemic has been facilitated with new advancements and applications of existing technologies. So I'm going to tell you a few technologies. Traditionally, we think of detection technology using a protein antigen test like ELISA or LFA, or a genetic material test like RT-PCR or NAAT or RT-LAMP. These are our PCR tests or nucleic acid tests. More recently, CRISPR, the gene editing tool, are able to target nucleic acid sequences of interest and can provide the sensitivity on par with RT-PCR. Not only that, using microfluidic technology is now able to do pairs of droplets for analysis, and they could test over 1,000 samples for a single virus or 5 samples of over 150 viruses. And these are fast, okay? And Luminex assays are the protein tests. With beads, they could do multiple proteins at the same time. You could figure out different viruses, and you could quantify them through this multiplex. The speed of detection has also improved with nanotechnology and biosensors, which give you high sensitivity and low noise, right? The traditional problem is high sensitivity and high noise. So it gets rid of that. The FET-based biosensors, for example, could give you sensitivity comparable to PCR, comes back in 20 minutes. It's based on sort of graphene surfaces where the charges will change after a reaction. Also, it has improved convenience. There's been development of freeze-dry synthetic biology sensors in masks, where it was dry and then if it's exposed to aerosol, and it turns and it rehydrates and activates and triggers a color change. So if you're wearing a mask and all of a sudden your mask changed color, you've just been exposed to COVID, okay? And your friends should tell you that your face mask just changed color. Population-based, our colleague, Mr. Pearson from Canada, told us about the wastewater surveillance. There's also emerging airborne surveillance, et cetera. So with the last few minutes, how many minutes do I have? Okay, take another 5 minutes. I'm going to tell you some new work that in my lab that we're doing, okay, using movement data to predict pandemic surges. Okay. So we had this idea that, okay, if we could track people's movement in a de-identified way, and if we know there's been increased density and dwell time, like the duration, so they say a lot of people are packed in a room, like this one, and for a long period of time, okay, will we see a surge afterwards, like a super spreader event, okay? And then, and also, does that matter if people are vaccinated? So we acquired Unicast data, which has GPS. I'll show you what it is. And then we got the fully vaccinated records from the CDC in the United States. We had confirmed COVID cases also from the CDC. And we used machine learning technique to analyze the data. So this is sort of what the data looks like. Somebody is staying in a place from like evening until the next morning they live there. Okay, that's called the row event. Now, there's travel events, and then also if they're staying in the same place temporarily during the day, they visited that place. And so there are different types of events that's happening using GPS data. And these GPS data are collected from a number of apps, the news apps, the social network apps, entertainment tools, communication apps, video players, finance, sports, business, dating, lifestyle. So these are different types of apps that aggregated these GPS data for us. So when we first started to look at the data, And we say, okay, let's just try restaurants to see what happens. We see that restaurants, time, duration, and draw time are increased during the weekends and the Labor Day, okay? So that sort of worked. Then we look at the venue cost distributions, and there's retailers, there's bars and restaurants, there's health and professional care stores, there's hotels, motels, there's real estate buildings, there's transportation. Okay. Now we classify from tens of different venues into the top 10 venues. So I'm going to show you what we did with full-service restaurants, limited service restaurants, and consumables, which are groceries and fuels. Okay. So the orange one is the incidence of disease, and the blue one is the predicted data. So using machine learning techniques and density, dwell time, and vaccination records, we are able now to predict a surge 3 weeks ahead of time. Now, wastewater is 1 week ahead of time. We are able to predict 3 weeks ahead of time in both different types of states. Blue states, like California, they're democratic leaning. There's usually more rules about wearing masks. Purple states, usually is a battleground state in the United States. You don't know which way they're going to lead in the presidential election. It predicts the same way. Red states are the Republican states that usually don't have a lot of restrictions on wearing masks. It predicts exactly the same way. And this is, again, another purple state. So we look at different regions of the United States, and either blue state, red state, or purple state is exactly the same. New York, exactly the same. We could predict 3 weeks ahead of time. Texas, exactly the same. So what's the policy implication? Venue-based risk assessment can inform policy interventions and strategies for reopening. You can't just randomly close a venue because you don't know what you're doing. You can't say barbershops, you can't operate barbershops. Well, what's the rationale? There's evidence that people wearing masks go into a barbershop, and if the barber is wearing a mask, the person is wearing a mask, you won't get infected. So why are you closing that, right? So what I'm telling you is that the restaurants, the grocery stores, in our opinion, could predict pandemic spread. We need to allow hospitals to prepare needed resources, the beds, the respirators, and the people. We could inform which venues should be temporarily closed or kept open. We could define allowable density levels, under which density we are not worried about the spread. Okay? So we could define that. So we could keep the reproduction number to less than 1 with modeling. There are some limitations to this study. It's a known, the masking rates in different states study, but it doesn't matter, okay? It's a known, the interaction between vaccinated and self-protective action. So if you wear a mask, if you get vaccinated, are you less likely to wear a mask? Or are you more likely to wear a mask if you're vaccinated? We don't know anything about that, but it doesn't matter. We could predict it already. It's a known if the GPS movement data will work in tall, large buildings in dense cities. So we don't know if this is going to work in Hong Kong or tall buildings, elsewhere. But we know that it works in majority of the states in the United States. It probably will work in Canada as well, because they're very similar. So comparable Australia, Canada, United States, I think will work. Indoor versus outdoor distinction. Unfortunately, many restaurants in Taiwan are indoors because it's generally hot here. And so you need to open it up, ventilation. Very, very important, okay, because once air is flowing, the virus just dissipates, all right? If you're indoors, virus is hanging out. Now Omicron is it's RT of 15 and above. It's like measles, okay? So you need to pay attention to that. So in the beginning of the pandemic, we worry about lives. Now we worry about livelihoods. So there's actually a connection between lives and livelihoods. So you have a whole bunch of inputs that you're tracking. Then what do you do about it? Then you have to have a risk-based system of modeling, the one I just showed you. So you could figure out what to do so that you could keep hospitalization rates down. Okay, death rates usually follow 2 weeks by hospitalization rates. And then you have to track the type of job recovery who's getting their jobs back, and the distribution of recovery. So I will end here. Thank you very much.
Thank you very much to Professor Jason Wang for your very informative talk. 非常谢谢王教授。Next, we'd like to invite Dr. Rongxian Jiang, CEO of Health Data Center, and also Distinguished Professor, Institute of Medical Informatics, National Cheng Kung University. 接下来呢，我们有请成大医院健康数据资源中心执行长，同时也是医学资讯研究所特聘教授。让我们掌声欢迎蒋荣先老师。Let's welcome Professor Jiang.
Thank you so much. It's a pleasure for last speaker. If I stop anytime, people were happy about it. Okay, my name is Jiang Rongxian. I'm very happy to be here to share a story of how we use AI platform to fight for health inequality and during the pandemic. So here is where we come from. We are right here, the Taipei. I'm coming from 300 kilometers far away from Taipei. It's Tainan. And this is our campus. I have several famous neighbors. And first one is, if you like baseball, you know the Wang Jianmin. He's the famous New York Yankee pitcher. And actually, I have another famous neighbor. Is the director Li An. And I'm sure if you like movie, and you know you can miss several of his famous movie. And he got an award last year, and because of his good reputation and contribution to the movie industry. So speaking of the digital health, I'm sure those 2 days, there's a lot of new topic, new subject, and particular previous distinguished lecture, they make a speech about the IT technology and something that can help in our environment. Well, something like preventive personalized medicine, or even different kind of subject of medicine. And currently, precision medicine and precision health got a lot of attraction recently. And it's because of, it looks like, just like United States ex-President Obama, he make a definition for the precision medicine. He say, the right treatment for right person at the right time. I'm sure this is very clear for this in the future medicine. And it would be good for not just right person, because our forums talk about healthcare for all. So I hope that the all person will be better. And I'm a computer scientist. I only know something about AI and IT technology. So all of those technology that can put together to help for healthcare, it's for treatment, it's for diagnosis, and it's for cure, and it's for prevention as well. So you can see, for computer scientists, they develop algorithm to data integration, as Jason just mentioned about, and also do clinical research, and all those technology will fulfill the need for precision medicine and for healthcare as well. You can see that in the future. And this is a typical photo from any developing country. You can see patient there, you see the family member there, and you see only 2 nurse assistants there, but no doctor, no physician. Why? According to WHO, where there's always insufficient medical professional in rural hospital. This is very rural hospital. Not just mention about Asian, Africa, or even South America. So rural hospital, there's always without medical professional, without physician there. I have a dream. how about bring those best doctors here from urban hospital to this rural hospital? That's my dream. And this is how we fight for healthcare inequality. We know that the healthcare inequality are complex, and it's everywhere in any developing country. They are preventable. I'm a computer scientist, so my dream is, how about this? How about let's bring best doctors here, not physically bring them there, but bring their skill from West London or even Harvard Medical School or even Stanford University to this rural hospital. So that is my dream. And we developed a platform to do that. My story starts from here. 2 years ago, more than 100 high-tech companies, majorly from Bay Area in the United States, they organized the first COVID-19 global hackathon. So many countries participate in this activity, especially World Health Organization also hosts for this hackathon. And you can see a lot of projects going on there. And I, with my student, so our team has only 2 persons. Later on, we expand to more than 10 people there. So we have a computer scientist, we have mathematician, we have a physician, we have a radiologist. We work together to make this platform happen. And we are the winner of that global hackathon. And what did we do? I'm going to explain that later to you. I'm going to explain that very detailed to you and how we make that happen. So this is a very general pneumonia detection procedure for any modern technology. You know, for a physician, they have to read that. They have to view this X-ray. So we ask those physicians to label pneumonia. That's a very common disease in any country over the world. So they can do this, find this consolidation, and this is a retrocardial, it's behind the heart, and those areas are ground glass opacity, which means there's some lesion over there. And this is the second part for AI platform to do that. So you can see after training for our algorithm for many days, and the computer become very smart to identify several areas. Okay, that's possible pneumonia. And later on, we developed for COVID-19, which is also a pneumonia. So this is a very clear example for our report that COVID-19 has very specific lesion area. And why we want to do this is because 2 years ago, for any real-time PCR, takes 2 days, or maybe later on take 1 day, and then you can identify that's COVID-19. But this X-ray, you can earlier, fast to detect that. And this is how we do that. So we make this platform available to general public globally. Well, this is a sad story, which is we really want to make a commercial product. And someone tell us, oh, this is profitable. But we decide to make this open to public. So that is the story. Okay, so this is exactly how we do that. In the middle part, you can see those are expert or even pneumonia expertise. They know this very well, and they help us to read those X-ray, and actually they let the experience keep there. So those hospital over there, you can see they took many different kind of X-ray data. And after all, this AI platform is able to identify the sick patient. And those are the idea that how we do that. So this is exactly we do that. It's an e-alert system, run fast, only take 1 second and can identify which person has pneumonia, or even ground glass opacity, or particular type of pneumonia. So later on, we train this technology, is able to identify COVID-19. And we train, use deep learning algorithm, which is just like Jason mentioned about, there's many different technology that can be used to make this computer available to do many different things. So we help rural hospital first. We let physician, I'm talking about inexperienced physician and doctor. After they use this, they feel much comfortable about their diagnosis because the computer will tell them this is very highly possible that is something going on there. So I'm going to make a very short video for you and let you know that how we do that. Thank you. Okay, so this is how it works, and this is how they do that. And you can see that this is a decision for this AI platform. It can be easy for 2 stages of that. So first stage is do the pneumonia segmentation and detection stage. And later on, we do that, the COVID-19 detection model. And then the best part and the beautiful part for this AI platform is the AI model perform like a human radiologist. So smart, fast, and precise. And this is something that we can like to show you. You start from Taiwan and expand to many other countries. Currently, there is over 20,000 of medical professionals globally came from 62 countries use this platform. Some physicians, they use every day. We can see from our back-end platform to see how it works and see how many people use this. So this is how they obtained from the front side. They can see from their original image. And later on, this is a suspected infection heat map. And also give them percentage of probability and also get a feedback as well. So this is how it looks like. Okay, so this AI algorithm is able to find the attention part and to see which area in the right lung probably is some kind of lesion there. And just like what I said, it's performed like a human radiologist. And this is a model for classification. And very clear, you can see some part which is able to identify for pneumonia and COVID-19 as well. We know that United Nations focus on the SDGs as. So our project here is focused on the good health and to fight for healthcare inequality. So our platform is free to access for any other country. If they want to use that, they can do that very fast example to do that. And this year, UNESCO named our team as top 100 AI team that is dedicated to this SDG goals. So here is the only one here. Then later on, UNESCO also named our team, thank you so much, as top 10 AI team, the only team in Asia. Okay. And so later on, we become very busy for that. You can see that this is Czech Republic, and they noticed that this is a very good example, so they just ask us for help. And later on, Kuwait. I want to particularly mention about this example is because I obtained a lot of photos from them. Before they use our AI platform, the people carry camels, you know, that in the desert and stay long line waiting for a PCR test. You know that takes at least a day or a couple of hours right now. But use this technology, they just give the physician feel comfortable, tell this patient, you are just cold, you are just a little bit fever, you can go home now. So this is example, and this is from Denmark, and then we have this webinar to explain that how the system can be used, and then make this, you know, to general public. And then this is for Finland, and then we got great opportunity to introduce this, and for different countries in Europe, their use. And this is Croatia, and also the good opportunity to know more about our user, because we know some country in Africa, we don't know them before, but we got their email, and they are really happy to use that platform to fight healthcare inequality. So together, we make a better world. Thank you so much.
Thank you so much to Professor Zhang. Would you please remain on the stage and join us for the panel? Yeah, do we have our staff moving the chairs and sofa? Yes, thank you. All right, ladies and gentlemen, next we have a 15-minute panel, and we can take your questions. So if you have any questions later, you can raise your hands or raise your questions online. 那接下来呢，是我们15分钟的 Q&A 的时间哦。那我们等一下呢，要邀请我们的主持人以及我们这个阶段的所有的讲师呢，都到台上来就座。And for that, we'd like to welcome back our moderator and also all the speakers in this morning's session to join us again on the stage. All right, let's welcome back our moderator, Dr. Wang. 我们再次有请我们的主持人黄荣誉院长。Mr. Pearson, would you please also join us on the stage? Professor Wang and also Professor Zhang on the stage. And joining us online, we also have Professor Karunathilake. Yes? All right. 那同时呢，我们第二位这个斯里兰卡的Karunathilake 教授呢，也会线上同步参与。All right. Would you please take your seats on the stage? And then over to our moderator, Dr. Wang. 接下来把时间交给我们的主持人院长。
Thank you very much for the 4 exciting talk this morning. Is there any questions or comments from the floor?
Do you have any questions for our speakers on the stage?
Please.
Yes, please let us know who you are before you ask the question. Thank you very much. Does the mic work? Yes.
Hello? Okay.
Yes.
Hi, hello. I'm Adi from the Ministry of Health in Israel. Thank you so much for all the information you gave us. It was very, very interesting and enlightening. I would like to ask Professor Chang a question. From all the data that you've been collecting, are you in fact collecting the data, and are you using it for research? Or also, what information do you think you can get from all that data collection?
Okay, thank you very much for your questions. Well, as you know that there's a lot of personal data there, obviously. We are very lucky in the early beginning of about 2 years ago, and a lot of physicians, a lot of hospitals, they identify the COVID-19. So they decide to put the data to open to public. So actually, all of our training data will come from the general public. For the public sector, you know that we do have a GitHub there. And several different countries, like I remember from Germany, from the China, and from United States, and they are major players. They understand this is terrible. What if we can share this data and take out their personalized information and just let people know how serious and how terrible this lesion or this infection for COVID-19. We are very lucky to start earlier, so we obtain many different data from there, from public, and then as our training data. So I'm sure that the lesson we learn from this example is, besides keep this data private for the training, we also add additional data from our hospital as well. And we do that very carefully, and we do have our security system for that. And as to the question you asked about how we learn from this, I believe this platform is just a starting point. It needs to be fine-tuned to become more powerful or even expand to different use. And we are particularly confident with the pneumonia detection, because this is a common disease, and it's, for different countries, they do have this very similar pneumonia for different lesions. And so this is the example that we learned. Hopefully, this then can be able to fine-tune to become something that was helpful for physicians. They just want to do diagnosis. Before that, take a look at this AI platform. Thank you.
Professor Junbo?
Thank you very much. I was also very impressed by the presentation by Dr. Chang. And I have been working in global health for many years, and I also have the same dream like you have. And my question is, I think what you're doing is a very good act of making technology as the public good or common good in the world. And you said this is just a starting point. And I wonder if you can make this movement to much bigger in the world, to make IT technology to the public common good. And I'd like to ask if this is possible for all the speakers, not only Professor Chan.
All right, so I will start at. So thank you for your encouragement. I'm sure this is just a starting point, and I'm very lucky to get a pass from Taiwan TFDA, and then we are able to do this platform. I'm sure that some of the speakers beside me, they also want maybe they can point out others application or possible application in their country as well, I'm sure.
So that's definitely possible. And I think the previous question about sharing of data is one method, but there's also, you could actually share the algorithm in a way that the data is run on site at the individual countries or hospitals. Because there's still a lot of nervousness about sharing data across different countries. And particularly, some technologies are easier to de-identify the data, others are not as easy. So for example, you can't really share a genetic sequence, without, that's the identifier for that person forever, right? So, but imaging, you might be able to mask it in such a way, and so you could you just need a data sharing agreement and also either that or another agreement to use the algorithm, proprietary use of the algorithm. And the purpose of that is not to say that who could use it and who couldn't. The purpose of that is you could make it proprietary, but make it zero fee, and so that that it wouldn't be altered in such a way.
This gentleman, please. Point.
Thank you very much for all the very enlightening presentations. My name is Sam Samarnaik. I'm from the University of Hong Kong. I'm an emeritus professor and the previous dean of the Faculty of Dentistry. So first I would like to ask Professor Chung, the final speaker, what is the sensitivity and the specificity of your system? And my second very quick question is, it looks like a fantastic system to me. So how do like the developing countries, like actually I come from Sri Lanka as well, but although I work in Hong Kong, share this how could these countries use this information, and is it freely available?
Okay, let me answer your second question
Yeah.
first. That's easy because this is public things. So you can just go ahead, use this platform anywhere, anytime.
Yes.
And back to your first question, I'm sure that we have, I don't have enough time to explain very detailed about the experiment test. So here is the general idea, let you know that sensitivity and specificity were general over 91% of that. And specificity kind of low a little bit. So in general, the whole accuracy is around 80%, something above 80% of the accuracy. So I will say that. Okay, if you're interested in that, I can show you the paper that we can publish before. Thank you.
Yeah, Dr. Karunasitek, maybe you also want to respond to this one?
Yeah, thank you very much for very interesting presentation. Yes, I think it's a very, very useful app using the artificial intelligence. I just want to highlight my point of view also, because Sri Lanka being a kind of a country with, low resources, especially related to technology, I just want to highlight the message that what we really wanted was to actually prioritize during that time period, what has to be done during that time period, and that that intervention that we used, the triage and the telemedicine initiative was actually based on the disease pathophysiology. As all of you are aware, the COVID disease has several stages, and you need to identify the patients and provide immediate measures at the correct time point, because if you wait till the patient to go into the period where it gets into pneumonia or into other phases in countries like ours, it is very difficult to manage them, because once you go into the hypoxia or the oxygen saturation becoming less and also the pneumonia phase, then it is a kind of a downhill course. So our priority in this, our intervention was to make sure that we detect them as early as possible and prioritize them. And that was done with few simple questions like what was the disease onset date? Are you vaccinated? Do you have critical symptoms like difficulty in breathing? How many days of fever? Because based on these and based on the pathophysiology knowledge, we can identify which phase the patient is in, and then direct to the immediate measures. For example, another measure that we have done was distributing pulse oximeters with the help of the military and the COVID National Center. We distributed pulse oximeters to all the diagnosed patients through our system, and that was also helpful, because when the pulse oximeter rating was available, and we were very strict, the moment it goes before 98, 97, we basically take immediate measures. So we have used this very simple measure, the pulse oximeter. So what I'm trying to highlight is that in settings like ours, where the resources are very limited, ICU facilities are very limited, we need to take immediate measures, prioritize patients, and that's why we had to use those very simple measures. The telemedicine system, asking the questions from the patients, immediately detecting what stage are they, and using pulse oximeter reading, we immediately direct them. So I think that was very, very important. And that was very strongly based on the measure of the principles of prevention, where you identify them before you go into the immediate, the serious station of the pulmonary or the lung complication of the pneumonia. Because in our setup, if you go into the pneumonia, it's very difficult. But if you detect them when the pulse oximeter reading goes down, when you detect them immediately when they basically go into say difficulty in breathing, you can save life by very simple measures. For example, by very good resting, complete bed rest, and then maybe change the positions to change the lung fluid balance, so on and so forth. And with simple drugs like steroids need to be given during that time period to prevent further inflammation, and antibiotics and oxygen. If you give these simple treatment immediately, you can prevent going them into lung complication. So that's why our priority at that moment was to identify the patient immediately and transfer them. Probably in our setting, that has worked well. And definitely this AI intervention is very good, very useful. The message I want to give is the interventions vary from country to country. And we have to really prioritize based on the resources that we are having. Thank you.
Yes, thank you very much. Due to time, maybe we can address the questions raised online for Michael first, and then we can collect one last question in the room. The questions for Michael online are, how much does daily wastewater testing cost, and any particular sets of equipment are needed for that? And how do you build up or win the public trust doing what you do in Canada? Mr. Pearson?
Thank you. Well, I'm a consumer, not a producer of testing. So my short answer to that question is I don't know what the cost is. But we're more than happy to work with the organizers to get that information and provide it to everybody. And I hope it can be of helpful, including not just cost, but the kinds of equipment that are used for it. Because I think the key message was this is an approach which has important benefits, and the more people that can use it, the more parts of the world that find it useful to use it, the better it's going to be for everyone. Building public trust, I think, is first and foremost about transparency, providing information, providing factual information from trusted sources that you then can communicate effectively to the public. Indeed, the wastewater surveillance information that comes from all of those different points that I showed on that chart across Canada, you can use that information that comes from those various sites can then be provided to the public, shown in the graphs, such as the graphs that I've shown, and then people can draw their own conclusions from it. But I think public trust is all about making sure that people feel confident that the information they're receiving is as unbiased as possible, scientifically produced. And this is a challenge in a pandemic. The pandemic experience has shown that lots of people who claim to have scientific information or do that analysis try to suggest that somehow it's equally credible with others. And one thing we haven't talked about, but is a consequence of the pandemic, has been what had been, I'm not a scientist, but most scientists would say that the best science and the most credible science is the one that's peer-reviewed, and it has been shown to be by others, when we say peer-reviewed, others who have the same background and skill set, who can say, yes, this has been credibly produced and is accurate information. And now in the context of the pandemic and the pressure for evidence, a lot of people have been producing so-called evidence-based information, which is not peer-reviewed or is put out there and then used on social media platforms to justify, particularly the conspiracy theorists use it to justify a view about whether masks, for example, should or should not be worn, how far away you should be from someone else, how the virus is transmitted. We've seen so many examples of false information that has come out, and how important it is when you get a confused public as a result of that, for credible sources and for public health officials to cite credible sources from science to indicate, what is something that has been actually more rigorously analyzed and assessed before it is provided, so that people can have more confidence in it. And I may just make one comment about data and data sharing. I think the key challenge about, and I think one of our speakers talked about this issue of privacy. How do you try to data share in a way that people can have confidence in the data but not worry about the privacy associated with it? And it's difficult. I'll use one example we've had in Canada, where my agency that I work in was trying to use cell phones as a way to aggregate information for the purposes of seeing how people's movements had an impact on how the virus spread. And there was a lot of when that became known to the political level or to our parliament, there was a lot of criticism about, well, how are you protecting people's privacy? You're invading people's privacy in doing that. And I think the answer to that question is aggregation, right? You emphasize how much things are done on the basis of aggregating a whole bunch of individual pieces of information which are not made available to the public, and in fact are not even collected. Getting the signals from where anyone's cell phone is and where they move. I remember early in the pandemic an example in China where people were showing the movement using cell phones of movement from Wuhan to other parts of China, the incredible degree of movement that was happening among people, and that itself was a good illustration of how the virus can move when so many people are moving from an area of high infection to other areas. That was all aggregated data information. There was no individual being identified. And that can be very useful for the purposes of public health decision making, is to recognize and see how that anonymous information is collected and aggregated, and then can help with decisions about what needs to be done to reduce the risk.
Yes, Dr. Wang?
Do you have any comment for that, the tracing of the population in the search of a victim?
Yeah, I think Mr. Pearson already answered most of it, but I would say that wastewater is a very good methodology, and many people are surprised that it worked, because initially people thought, well, how do you make sure you're sampling the sewage water correctly? And then we were a little surprised with contact with the movement data as well. So there are many ways to address the question. Now, I would say that there's a prior question about how sensitive and specific a test needs to be. It depends on the prevalence of disease. In a low prevalent situation, right, any screening test, when it shows up positive, is most likely to be false positive. But when the prevalence goes up, even a screening test, that's not so good, most people are likely to be true positives. So really, you really have to just do a simple back of the envelope calculation, take the sensitivity of a specific test, either it's PCR or rapid antigen, and just model it out based on prevalence, and you will quickly figure out what percent is going to be true positive, what percent is going to be false positive. And then in the case of AI algorithm, it's the same, because if you have a lot of people infected, then most of the cases are going to be true, and when you screen them out, when you screen them in. But if you only have a few cases, it's very difficult to develop an algorithm. So that needs to be adjusted by the prevalence at that time. That's my opinion.
Yes, moderator, would you please wrap up this session for us?
Thank you very much for the discussion. It's very hot topic this morning. We have so if there is still any question or comments, please contact the speakers in the floor after this section, because time limited. We should close this section. Thank you very much for everyone.
Thank you so much. Once again, a big round of applause for all of our speakers here, and also thank you to Professor Karunasilake. joining us online. Thank you so much. Bye-bye. Thank you. And thank you to all our speakers in this session for their wonderful discussion. Ladies and gentlemen, it's time for lunch, and we have lunch boxes ready outside for you. And we'll take a break until 1 o'clock this afternoon. And when we come back, there will be 3 sessions going on at the same time. And here in this room, we're going to talk about dementia care. And you can go to the 8th floor for Super Age Society, or go to the 10th floor for traditional medicine. All right? We'll see you later. Enjoy your lunch. Thank you. 那接下来呢，是我们中午休息的时间。我们在场外呢有准备好餐盒了。我们休息到下午1点，休息到下午1点。那下午场回来之后呢，是3场的平行场次哦。在我们的主场呢，要探讨的是失智症照护。那如果您要参加的是超高龄社会的场次的话呢，要请您移驾到8楼。那如果呢是要参加传统医学场次的话呢，我们的会场在10楼。那同时呢，大家用完餐有时间的话呢，都可以到10楼的这个展览去参观呢。And also after the lunch, if you have time, feel free to pay a visit to our exhibition on the 10th floor. We are showing some latest AR, VR solutions and assistive devices. Thank you very much for your participation in this morning. Thank you. Ladies and gentlemen, the afternoon session will begin in 3 minutes. Thank you so much. Here with us in this room are speakers who are going to talk about dementia healthcare. And we also have another session on super-aged society on the 8th floor, or another session on traditional medicine on the 10th floor. Thank you. 各位贵宾，我们下午场呢，再过3分钟之后就要正式开始了。那我们本场次呢，要聚焦的是失智症的照护。那同时，如果您要参加的是超高龄社会场次的话呢，请您移驾到8楼。那到10楼的话呢，则是传统医学的场次。谢谢。Welcome back, ladies and gentlemen. In this session, we're going to talk about how to turn Okay, welcome back, ladies and gentlemen. And in this afternoon session, we're going to talk about how to turn Taiwan into a dementia-friendly island. 那接下来呢，我们今天下午的大会主场的平行场次哦，我们要聚焦如何将台湾打造成为失智友善的岛屿哦。And to moderate this session, ladies and gentlemen, please join me in welcoming our moderator, Dr. Ci An Guo, Associate Professor, School of Medicine, Zhongshan Medical University, to the stage. 那接下来呢，我们就掌声有请我们场次的主持人，中山医学大学郭慈安副教授上台来为我们开场，掌声欢迎 ，Let's welcome her.
Good afternoon, everyone. Yeah, welcome to our afternoon session. We're going to have a very exciting session, and not only that we have a very brilliant and excellent speakers, but also there's an important figure in our government position that actually showed up here to be with us. So first, let me introduce the Director of Long-Term Care Department of our Health and Welfare Ministry, Ms. Director. Thank you for coming.
我们欢迎司长。
前方 Director 司长，谢谢，欢迎。Dementia in Taiwan is a relatively new term. However, Taiwan is working very, very hard to catch up. Today we are going to have a session actually pre-recorded by Ms. Paula Barbarino. She is actually the CEO of Alzheimer's Disease International. And then we are going to be followed with 3 speakers. First one is one of the doctors that I respect a lot, Dr. Bai Mingqi, doctor. Let me introduce him. He is a director of Alzheimer's Disease Research Center at National Cheng Kung University. Dr. Bai has dedicated himself to a lot of Alzheimer's research. But interestingly, as I was reading the bios of all the speakers today, I found a very common theme across either Ms. Barbarino or the 3 speakers from Taiwan. Actually, I found that Ms. Barbarino graduated from a classics major or archaeology major, and later on she obtained a library degree. She was very fond of arts and culture, and then that's really similar to 3 of us who are really dedicated to a lot of arts and humanities in dementia care. So I'm sure today we're going to share with you a lot of the artistic and the cultural natural of dementia care, and then show you how Taiwan is different from the rest of the world in dedicating ourselves to the dementia work. We are the 2nd Asian country that had a global national plan, followed by the WHO Global Action Plan. And since 2017, we had formed an action plan, and under the action plan, many of the government entities and departments work together, from literacy to long-term care to transportation to maybe labor, and most importantly, to increase the literacy of dementia among the public, and also try to reduce the stigma that we had for dementia family and individuals. So let me first, and I missed actually a 2nd speaker after Dr. Bai is Director Chief of Chen Junyou 先生. He is the social work chief of a very important organization in Taiwan, the Taiwan Catholic Foundation of Alzheimer's Disease and Related Dementia. Mr. Chen actually is a multi-talented person. I first knew of him as a commercial actor, actually. But he was actually indeed all the way a social work indeed. He has dedicated himself to dementia work for more than 25 years. But he has a very special way, along with the foundation, to educate the public by producing a lot of plays, a lot of theatrical events, and also numerous documentary movies that are very famous in Taiwan. I am the beneficial of this foundation because we often use the movies that they produce to do public education, which is really, really helpful. Instead of boring lecture, sometimes watching a play or a movie followed by actually an expert explanation of dementia symptom and also talk about dementia resources is a very powerful way to do public education. All right, and then the last speaker is going to be me, which I will introduce myself later. So let's get started this session. I think first we wanted to welcome Ms. Paula Barbarino, and she has actually pre-recorded her session. And in fact, actually, I wanted to also introduce you that Taiwan is actually going to be the host of ADI Asian Pacific Conference later in December. And today is the last day for early bird registration. So if you are interested in coming again to ADI conference in December, please remember to register today. And then so let's welcome Ms. Paula Barbarino for her lecture. Okay, so.
Good morning, good evening, ladies and gentlemen. I am Paola Barbarino. I'm the CEO of Alzheimer's Disease International. It's a pleasure to be with you today. Thank you for listening to my presentation. I'm going to share my screen with you in a minute. so that we can all see it together. I'm going to talk to you today about supporting those living with dementia through a national dementia plan and the insights that we have derived from publishing this year's World Alzheimer's Report 2022, which was on post-diagnostic support and care. A word about ADI, for those of you who may not know who we are. We were established in 1984. We are the umbrella organization of 105 Alzheimer's and dementia associations around the world. We represent our 105 members plus 20 countries in our development program at the WHO, the UN, OECD, and other global and regional bodies. In Taiwan, our member is TADA. We are the promoter of World Alzheimer's Month, and we are the publisher of the World Alzheimer's Report and other reports. I know that in Taiwan, you've just held the World Alzheimer's Month, a very successful one, and I commend and thank you for your commitment to that. Our vision at ADI is prevention, care, and inclusion today, with the hope to have a cure tomorrow. Our strategy has been quite interesting and is worth spending a few seconds on it. We were created, as I said, in 1984 by 4 of the largest Alzheimer's associations, the US, UK, Canada, and Australia, who felt very strongly that there was a lack for an international body to advocate at global level. If you think that cancer and Alzheimer's were discovered pretty much at the same time, the 2 international bodies behind cancer and Alzheimer's were funded at very different times. So the IUCC, I think, was funded around the 1930s. And this just shows you the amount of stigma that has been around dementia, that the movement didn't even get its act together at multilateral level until much, much later. The first few years of ADI's existence, we spent them building the network of 45 members that gave us official status with the WHO and the UN. And after that, we advocated very strongly for the creation of a global dementia action plan, because we did believe, and we still believe, that only governments have the keys to scale up any kind of dementia program. And I know that your government, together with TADA, has been working very, very hard to improve the life of people living with dementia and their families in your area. However, this is not the case in the vast majority of the world. So after the plan was approved by WHO in 2017, our strategy changed. And we decided we didn't want the plan just to be a piece of paper without funding, without presence. We wanted everybody to adopt it, should adopt it. All the countries that had signed to this international agreement, we wanted them to honor it. So we have increased our multilateral presence at the OECD, the G7, the G20, and all kinds of other global bodies. And we started a high-level ambassador program. We then strengthened the regional networks at civil society and government level. In Asia, for example, we've been working a lot more with ASEAN and with the Asian Development Bank. And we have been working at national level with a number of countries whose healthcare structures are just not strong enough to develop their own plans. And we've been trying our uttermost best to help them doing so if they have an intention. But our last piece of strategy, the one you see on the right, is to have realized that without the mobilization of citizens wanting change, change is not going to happen. And World Alzheimer's Month has been our mechanism to do this more and more, and to be more present in the press, and to be more present generally. And this has yielded massive results, with millions of people now taking part. But let me take a step back and tell you a little about the global impact of dementia. So as we published many years ago, and unfortunately still the case, every 3 seconds someone in the world develops dementia. The total estimated annual worldwide cost of dementia was $1.3 trillion in 2019, and the figure is forecasted to reach $2.8 trillion by 2030. The number of people living with dementia has now been set at 55 million people in 2019, growing to 78 million in 2030 and 139 million in 2050. Indeed, in certain areas of the world, prevalence forecast for 2030 is of over 1,500%. And that is extremely shocking, and we are looking more at this result. And there may be a number of reasons for this to be happening. But let me take now back to the WHO Global Action Plan. So the Global Action Plan was published in 2017, and it has a deadline of 2025. And every year since then, we've been publishing a report from Plan to Impact that is charting the progress towards the plan. The plan is brilliant. It's got 7 areas: dementia as a public health priority, as awareness and friendliness, dementia risk reduction, dementia diagnosis, treatment, care and support, support for dementia carers, information systems for dementia, and dementia research and innovation. And it is our belief that all of these areas have to be met for people living with dementia and society in general to really benefit from a plan. However, it is a very ambitious task, and we are fully aware not all countries can actually start any or many of these areas. And we are currently advocating to countries to start at least working in 2 or 3 of them building up to a stronger participation. Why do we continue to insist on national dementia plans? Because national dementia plans offer the best tools for diagnosis and then for post-diagnostic support. They help raise awareness and combat stigma. They do look at the issues related to healthcare professional training, which is becoming such a huge issue. And we ourselves at ADI are now taking on a healthcare accreditation because there is a huge amount of demand, but really not very many courses that are professionally accredited. It's also important because we do need risk reduction strategies, and there are so many areas where the risk reductions for dementia are the same as for other non-communicable diseases, but also there is a lot of specific areas that are just very specific to dementia that we need to take into consideration. Also, a plan helps us track prevalence and incidence so we know where we are. Are we getting any better, for example, with these risk reduction strategies? And finally, and very importantly, especially for you, is the preparedness for a breakthrough. This year, we have had some really interesting and very heart-moving news about possibly new therapies, but our government prepared for the onset of these new therapies. The reality is that in our experience, they are not. So national dementia plans, just to give you a panorama, a view of which countries in the world do have plans, which countries in the world have a plan in development, those in gray, and those countries in the world that do not have plans. And although in this map it looks like they are a smaller part of the world, believe you me, it is the opposite. Only 40 countries really have plans, and the vast majority of them have nothing. In certain countries, I'm thinking in Asia, for example, Laos and Cambodia, there is not even a civil society organization, not even an association of doctors and nurses. There is nothing. And we are desperate to get more countries into the awareness element. Our survey in 2019 around stigma on dementia revealed that 62% of doctors and nurses, healthcare professionals around the globe, believe dementia is part of normal aging and not a disease. So with this challenge of training of doctors and nurses in mind, what are our chances that the larger part of the population understands what dementia is and the fact that it is a disease, help is attend, and a better life living with dementia is possible. So now I'm going to talk about our World Alzheimer's Report 2022. Every year, Alzheimer's Disease International publishes a World Alzheimer's Report. Last year, it was on diagnosis. This The year before then, it was on design and innovation for dementia. The year before then, it was on stigma and attitude to dementia, and so on and so forth. Every year is a different topic. This year, the topic was on post-diagnostic support. And we wanted this to be a companion report to the one last year, understanding that there shouldn't be diagnosis without post-diagnostic support. Families should be able to have a path, navigate through the complex healthcare systems that will give them hope after a diagnosis rather than launching them into despair. And in lower income countries, the issue of despair, the issue of depression onsetting after a diagnosis is still, unfortunately, a big issue. But also so in some high-income countries, where in particular in rural areas, there is often no coverage and still a lot of stigma. But let me tell you a bit about the World Alzheimer Report 2022. So the biggest finding was that 85% of people living with dementia are not accessing post-diagnostic support globally. And let me go more into detail. 2 in 3 people living with dementia said they did not have a personalized care plan. This was in a small but significant survey that we did for this report. 54% of carers felt stress often or all of the time while trying to cope with their caring responsibility. Globally, 58% of people living with dementia said that they did not have access to a key worker or to a navigator after their diagnosis. So people are left without knowing what to do. And just as TADA publishes a lot of information on what to do after a diagnosis, so do our other 105 member organizations. So this also posits the question, if the information is available, why is there at primary care levels, doctors are not simply signposting to it? And this again goes back to governments. If governments do not increase the training of doctors and nurses, what is the chances that they would even know that dementia is a disease? As we said in our survey in 2019, 62% of the many people we polled 70,000 people that year, said they didn't even believe it was a disease. So if the doctors are not signposting, it's because sometimes they don't even know that the information is available, but at times they also don't believe this is a disease that is worth following up. This is an extremely sad situation. In the World Alzheimer Report 2022, we also find out that 45% of people living in dementia in low and middle income countries say they were not offered the support following their diagnosis. 2 in 3 carers from low and middle income countries said that those they care for had not been given access to post-diagnostic support. 37% of people living with dementia in high-income countries say they were offered nothing following their diagnosis. So this goes back to the point that we think at times in high-income countries the situation is better, but actually it is even worse in a way. The countries that have the resources still present such a stark situation. 37% of people living with dementia in high-income countries say they were offered nothing following their diagnosis. So the World Alzheimer Report 2022 offered some recommendations. The recommendations are several. The national dementia plans need to become a policy priority. If they're not a policy priority, nothing will happen, and there will be no funding critically. Person-centered care must become the norm, and I know that you in Taiwan are trying so hard. And I think this is the big challenge, not just for dementia, but for so many other diseases. We must try and do better on person-centered care. Every individual is different. Care should also be culturally appropriate, and it should be gender inclusive. And our report goes in great detail about what this difference may make to the population. Also, we must prioritize support for carers. If you remember in my presentation slide earlier, Support for carers is one of the planks of the Global Dementia Action Plan, but is very often not prioritized at all. Carers can lose livelihood, can lose their family, can lose their circle of friends. They can become isolated, they can develop mental issues. It's incredibly important that the person that cares for someone is themselves supported in order to do the better job possible, but also to maintain their own quality of life. And that's so often forgotten. Care also needs to be coordinated and accessible, and often it is not. It's very difficult for people to understand what services are available to them, if any. We also must continue to challenge stigma and continue to raise awareness, because it does remain a very severe barrier. Education has to be improved and expanded. Further trials of cost-effective and evidence-based psychosocial intervention are needed. And this is so important because we talk about education. So many people don't know. There was a report by OECD in 2017 that established that in high-income countries, doctors and nurses only receive 12 hours of training on average on dementia, and that is just so low. And this also impacts on the psychosocial interventions. A lot of people don't know they exist. They continue to try and use pharmacological intervention when actually psychosocial intervention are perfectly adequate and make a lot more sense, therefore bringing us back to patient-centered care. This is all a circle of things interlinked to each other. And risk reduction must be bolstered. There is a lot that we know about risk reduction, but very little that governments are actually doing. For example, a lot of people don't realize that hearing has been connected with developing of dementia. That's one of the latest things. That pollution similarly has been linked. There are strategies around these, and people should be more aware. We provide a lot of information on our website. We provide a lot of information to our members, but this has to be disseminated. So what the scientists find has to become practice and policy, because otherwise it's absolutely make no difference to people at all. So those were some of the recommendations of our report. Tomorrow there is going to be a Q&A on this series of lectures, and I will not be able to take part in it as I will have returned from South America, and my time zone will not allow me to take part in the Q&A. However, I am aware that some of what I have said may have raised questions with you. And so given I cannot be part of the Q&A, I can suggest that you can connect with me on LinkedIn, on Twitter, or by email, and send me your questions directly. In any case, please do stay connected with ADI. Dementia is a very fast-moving area. I haven't even touched on all the therapeutic breakthroughs that are on the horizon. There are some promises trials that are coming out with very interesting reading, and there may well be the possibility of a disease-modifying therapeutic in the short run. Are we prepared for it, and what does this mean? There is so much more we could have talked about, but I thank you very much for your attention, and I invite you to keep being connected with ADI if you're interested in the field of dementia, and I invite you to be more interested because the rate of growth is massive, and as I said, is becoming an increasingly larger problem for the whole of the world. So I leave you with this slide containing a lot of our members all over the world that makes us so stronger, and to try and follow us on social media and help us all during World Alzheimer's Month. I thank you for inviting me, and I wish you all a very good day at the conference. Goodbye.
That was a very short and concise talk, and it really gives us more guideline for what we are missing and what we need to do in the future, especially the 2022 plan that really highlight that we have to think of dementia as a holistic way, and it's going to be a lifelong journey, and the family needs a lot of support from all of us. Okay. So next, I'm going to start introducing the first of our Taiwanese speaker. The first one is going to be Dr. Bai Ming-Qi. Dr. Bai, to me, is a very romantic doctor. Yes, a very romantic doctor. You will like him a lot. I first knew of him actually when I was asked by a government entity to go check up a support center for dementia in Tainan City. Tainan City is a very classic Taiwan city, very historic. And then it turned out that support center was actually founded by Dr. Bai, a Zeelander Society. And Zeelander actually is the name of the Dutch, I think, right? When it first found Taiwan, Taiwan used to be called Formosa about 400 years ago. So from that society, actually, Dr. Bai started a lot of family support and also put up a lot of events and wrote books that what family had to go through when they were diagnosed with dementia. But Dr. Bai actually serves many positions. He was the president of Taiwan Dementia Society, and he's also president of the Zealandia Dementia Association, as I told you, and also a professor of Department of Neurology at National Cheng Kung University, and also director of Alzheimer's Disease Research Center. Wow, that keeps him very busy. And also, he's also a director of a very famous academic program, a gerontology program, the only gerontology graduate school in Taiwan. So that's welcome, Dr. Bai.
Ladies and gentlemen, good afternoon. Thank you so much for your kind introduction. I'm not so romantic. I'm Ming-Chi Pai from Tainan, Taiwan, a very old city in Taiwan. And as mentioned, there is a very old fort called Fort Zealandia. Actually, was built by Dutch about 400 years ago. It's my great honor to be invited to share my experiences in integrated dementia care in Taiwan. So today, I will be sharing in 3 major sections. In the first section, I will be talking briefly about the long-term care services in Taiwan, followed by an introduction to Taiwan government's national dementia plan, what kind of objectives and what and how services specific to dementia are carried out currently. Then I will share with you my personal experiences as well as those from 5 other outstanding centers in this program. Population aging actually is an issue that all developed countries in the world are facing today. In 1903, Taiwan officially entered the Aging Society, and then in 2018, the Aged Society. It is estimated by 2026, Taiwan will become a super aged society. Therefore, we have to prepare for our responses to the challenge brought about by rapid population aging. In 2022, about 4 million people are 65 or older in Taiwan. This really casts a huge burden to the society and young people. As Taiwan is approaching a super aged society in 4 years, dementia, a product of aged society, is arguably the #1 issue we must face. From TADA, Taiwan Alzheimer's Disease Association data, that we have 4 million of older adults currently. Among the 4 million of older adults, about 4 million people, 300,000 are with dementia, and about 700,000 are with mild cognitive impairment. Even you close your eyes, these figures will not change. We need to face it. Next, I will introduce the long-term care services. This slide shows a brief picture of the process and the stages of long-term care 2.0. Here are two missions of long-term care. First, to extend healthy life of the older adults in Taiwan. Secondly, as for those already stepped into frailty and disability status, we try to maintain their features and shorten a bedridden time at the same time. The target service participants of long-term care services are shown in these slides. Most are 65 or above, and one of the exceptions is those with dementia over 50. This slide shows the overview of long-term care services. It looks complicated. Fortunately, it is not my topic today. My topic is integrated dementia care, and its position is here. It's here. In the services delivery system, care plan coordinators, or A, are the key persons. They evaluate disability level and the needs of the applicants before connected them to various care services in the community, namely B and C. The long-term care provides their care, health promotion activities, respite, transportation, catering services, and consultation. The main objective is to enable older adults age in place. In Taiwan, we have a comprehensive project called the Dementia Preventive and Care Policy and Action Plan that has already processed to version 2. In version 2, there are two main objectives. The first is timely diagnosis and intervention. As well known, doing so can have benefits for mild cognitive impairment and dementia patients, as well as reducing the financial impact on family and the national health insurance. Secondly, we know there are tremendous mental and physical stress of family members of dementia patients, and we hope to provide them with adequate care and services to maintain the dignity of dementia patients and improve the quality of life of the whole family. For these objectives, the government has set a clear goal, which was 2020 555 and 2025 777. The first 7 are where 70% or more of the dementia family caregivers receive support and training. The second 7 are where more than 70% of those with dementia are diagnosed and receive services to slow down deterioration through early intervention. The last 7 are related to society, where 70% of the general population possess correct knowledge and a friendly attitude toward dementia, making our society in general a dementia-friendly environment. To achieve these objectives, we need some core strategies. The government has set 7 major strategies to achieve the 777 target. These are 7 strategies. The first is arguably the most important. It is to recognize dementia as a public health priority. The second strategy is to raise dementia awareness and friendliness through media advocacy to improve the public's correct knowledge of dementia. The third strategy is to reduce the risk of dementia, such as decreasing the risk factors for dementia like obesity, diabetes, and smoking, and to promote people to actively reduce their own risk factors. The fourth is to provide dementia diagnosis, treatment, care, and support to improve medical personnel and caregivers' professional knowledge and skills. For example, caregivers in long-term care were required to earn credits through many online courses, which I think have significantly changed the way these people learn knowledge. The fifth is to provide support from those who care for those with dementia, like caregivers and social workers. There are many places in Taiwan offering respite services to relieve the stress of caring for people with dementia. The sixth is to build an information system for dementia. This is done through epidemiological surveys and investigations, building the National Dementia Registry and the surveillance system. The last strategy is to promote dementia research and innovation through new technology to improve the quality of life, quality of service. Tainan, where I come from, Tainan Dementia Care Model, as established in 2014, is centered on patients living with dementia and their caregiver. The staff of the Dementia Center talk to each patient and caregiver to fix their met needs and promote the literacy and awareness of dementia. In the center, the staff of different backgrounds interact with each other to improve their knowledge and skills. Through care managers, the social resources are connected to the dementia patients and their caregiver. Through knowledge exchange, a network is set up among regional hospitals. I believe this is the prototype of integrated dementia care in Taiwan. In 2016, we introduced Kumamoto Dementia Care Model to Taiwan. Professor Ikeda is the key person. This is the Kumamoto Dementia Care Model. This model emphasizes on a regional network led by a medical center to provide correct diagnosis and deliver good medical care. Kumamoto model had been one of the best dementia care models in Japan. In 2016, we also visit Nordic countries to look for the best ways for Taiwan to solve the issue raised by aged society. Eventually, a decision was made to enable older adults age well in community. A new program called Integrated Dementia Care launched several months later. The program of Center for Integrated Dementia Care launched in 2017. The main working units include centers, stations, the care center for dementia, and the related facilities with innovative design. The goal of the CIDC are to promote literacy of dementia, to enrich the social resources for dementia care, and to provide the services to people with dementia and their caregiver. Moreover, this program also put emphasis on early detection of mild cognitive impairment due to occult dementia and urge them to visit dementia specialists for timely diagnosis and management. It began with 21 sites around the nation in 2017, and the number increased to be 115 in 2022. As the awareness of dementia had been highly promoted, various services come up. As you can see, in addition to CIDC and stations, more and more services are delivered from community and the institution to the users. Here, I will share with you several outstanding centers in Taiwan, and most of them started their service long before 2017. Chang'an Memorial Hospital is the first ADRC in Taiwan. They have a very unique daycare center with facilities for light therapy. They also put emphasis on job redesign for people living with young onset dementia. Featured services include training program for foreign caregivers, lectures for legal issue, and a school of wisdom. Next to the Chang'an Memorial Hospital, ADRC at NCKU is the second ADRC and the first national ADRC in Taiwan. I am the director of the center. All three pillars for successful dementia care are to promote social awareness, to enrich and bridge social resources to patients and caregivers, and to train medical professionals to keep correct diagnosis, to make a correct diagnosis at the right time. We have many innovative programs, such as Lehigh Pass, a kind of social prescribing to encourage people with MCI or mild dementia to visit museums, and many slogans to encourage citizens to choose healthy lifestyles. We also deeply have been collaborating with Zealandia Dementia Association to promote awareness of dementia over the past decade and teaching people the ways to keep away from dementia. This slide shows the Lehigh Pass. The Lehigh Pass and slogan and many awards obtained by ADRC at NCKU Hospital. Far East Memorial Hospital has one of the earliest memory clinics in Taiwan. Recently, they have been using a dementia ability Montessori way model to slow down the progression of dementia, and they have a very good training program for caregiver. Moreover, they have outreach services to promote dementia-friendly community and organization. They also have a telecare program for dementia patients, which is indeed important in the pandemics. The next is Taipei Medical University Shuanghe Hospital. Their missions are very clear. The first is to make a diagnosis. The second is to support community-based dementia care station. The third is to strengthen the role of case managers. As you can see from the upper right, the rates of admission and emergency service visit are reduced by a suggestion from care managers. Finally, the fourth mission is to promote awareness of dementia. Zhanghua Christian Hospital is in Middle Taiwan. They have different types of care model for dementia. Dementia patients from very mild to severe status, and provide acute care. Like the other outstanding centers, Zhanghua Christian Hospital staff set up a platform, promoted function of case management and the combined long-term care services before the launch of the program of CIDC. Although the numbers listed in the tables are far from the estimated population of dementia and MCI previously I mentioned, more and more people living with dementia and their caregivers have received services from the centers for integrated dementia care from 2017 to this year. Via the contributions of the centers, the awareness of dementia has been promoted further. The stress of caregiver much relieved. The skill to take care of their loved are improved, and the patients are safer than before. And the progression of the cognitive and functional decline is slowed down. As I know, the next speaker will talk on topic of the supportive center for people with dementia and families, which is another program under the National Dementia Plan. So we may come to a conclude now. So before the integrated dementia care program, dementia in Taiwan is underdiagnosed. It was a stigma. People with dementia and their family caregiver were helpless and hopeless. Now, users basically are satisfied with the integrated dementia care services. But curiously, nearly all people with dementia in Taiwan have been diagnosed according to the National Health Insurance Data Bank. Is it overdiagnosis or not? I don't know. In the future, many people in Taiwan are worried about the fate of CIDC. Will it be merged to long-term care services? And are the aims of the CIDC realized really? I would like to thank Department of Long-Term Care, Ministry of Health and Welfare Taiwan, and the Dementia Center and at Chang'an Memorial Hospital, at NCKU Hospital, Taipei Medical University Shuanghe Hospital, Far East Memorial Hospital, and Zhanghua Christian Hospital, because part of the contents are currently provided by them. Thank you for your attention.
Thank you, Dr. Bai, for providing us a basic understanding of the Taiwan long-term care plan and our latest Taiwan long-term care plan and our dementia action plan, as well as using the 5 hospitals as example to show you how many of our hospitals are dedicated as integrated center for dementia to coordinate the array of services. And there are about 116 integrated centers in Taiwan. Taiwan is a small island, but we have already 116 of them coordinating dementia services for families. So I think we're catching up. We're working very hard. So from hospital to community, and now with community, what can we do in the community? There are so many things that we can do, actually, from public education, dementia literacy, to services in the community, as well as one thing very important that our next speaker actually brought to us. Many years ago, social work chief, the next speaker, Chen Junyou Xianxin, Miss Chen Junyou, he actually told me the importance of taking care of the staff who are working with dementia, and also the importance of self-care for the dementia family members. So what I admire about the Catholic Foundation of Dementia-Related Services is that they have dedicated so much to actually bringing our understanding of, we're all in this together. Either you are a bystander, you're a neighbor, or you're an educator, you're a professional. We all need to take care of each other when we face dementia. So let me introduce Social Work Chief Chen Junyou Xianxin, Ms. Chen Junyou from the Catholic Foundation of Alzheimer's Disease and Related Dementia. Mr. Chen has been dedicating himself as a medical social work before and also working as a social work chief for 23 years in this foundation. And he has actually represented Taiwan to many of the services and also across the board in the nation to do a lot of exchanges. And he has dedicated himself to being a true educator for the public. So let's welcome Mr. Chen.
Ladies and gentlemen, good afternoon. Thanks, Teacher Guo introduced me. It's my honor to present our work in Taiwan. Okay, you saw this before, so I jump it. Okay, so in the World Alzheimer Report 2022 recommendation, the fifth care needs to be coordinated and accessible. Because in Taiwan, in our Chinese culture, we take care of our family with dementia at home up to 90%. It's higher than United States and Japan. The survival years after diagnosis of dementia, about 7 to 8 years. Some can extend to about 15 to 20 years, such as cause the disease is brought to the patient and the considerable burden on caregivers. Because the BPSD, so if the family cannot deal with this, that will be it's a mystery. So if the patient has such BPSD, maybe they will send to the nursing care institution. In 2012, we saw a story in Jiayi because the care his mother, it bring me a depression situation. We do so much, but when and where will happen this mystery? So we begin to think what to do. In 2012, we begin our okay. In order to let everyone know that it's not a shame to have a demented person at home, you need to find resources to help in. So we cooperate with United Day News, invite 26 celebrities, or include our President Tsai Ing-wen. She told us, because she herself is a family caregiver, she knows the hardship of such family caregivers. So after she took office, was more in investment in long-term care and the demand license than before. This is St. Thomas Alzheimer Community Center in Wanhua, my work place. Specialized in caring for elderly with dementia. We made a documentary and released it theater all over Taiwan in 2010. You can see, you can scan this QR code and to watch the film, but not now. Okay, maybe later. There are two grandma. One is Sui Mei. We took good care of her, so it's been 17 years since she has been diagnosed with vascular dementia in 2005. The other one is Jin Zhen grandma. It's over 19 years. So, but not everyone not every dementia became the burden of their family. Christine, one of the world famous people living with early onset dementia, it's been diagnosed for 27 years, but she still lived and became a dementia advocate and writer. In her book, she told us we should be the caring partner, not the matrix. So if you can, so after that, we skip this because you already be taught. In Taiwan, okay, more and more people with dementia. So our government do much things on this. Okay, so that's Dr. Bai already told. But Christine reminds us, nothing about us without us. Because the real experts on dementia are people with dementia themselves. So let me introduce a friend of mine, Mr. Lin Tianfa is 95 years old this year. He lived in Jiayi City. When he was 73 years old, he and his wife were both diagnosed with dementia, Alzheimer's disease. Constructing a health life, praying Tai Chi is Chinese Kung Fu in the morning, and volunteering at the community care center, caring other people, elderly living alone or disabled, teaching Japanese because and eating healthy. That's we call a good lifestyle, and gradually improving dementia. And last month I went to Jiayi. He came to see me, and he told me he already he want to live more than 100 years. So we make a story into a documentary to give everyone more hope for dementia, not always sad about this disease, in order for young people to tell about the correct concept. So we also publish the comic books. We use this experience in our Dementia Community Service Center. And we begin the lifestyle redesign group for people with mild dementia and their caregiver since 2016. And cooperative leader training with the Department of Long-Term Care and the Health of Taipei Nursing and the Health University. In this year, there are 72 people, leaders, have been trained in Taipei, Taichung, and Tainan, especially thanks Teacher Go's help that we can do this in Taichung. In the future, it's hoped that the training will be carried out year by year to expand to the dementia community service spaces all over Taiwan. And we make another documentary film, Remember Me, because it's the member of the group, and we started the movie at last year. This year we show it all around Taiwan. And okay. Then we already have a comic book, and this version we have translated into English. If you want this comic book, you can tell me later. Maybe we can send you after the meeting. Okay, this is the public service stage show. I Love Grammy, and we start this show from 10 years. And after the show, we invited the professional caregiver and the people with mild dementia, like Bai Wanzhi or Liu Renhai Mushi, or very famous person in Taiwan, Li Fuchen, 气象主播. After that, we can communicate to the audience and them really understand what happened to the disease. Okay, so in hospital, we diagnose dementia, and after that, we serve our not only 1966 the highlight. We should we still have many highlight in Taiwan, or want to help the people with dementia or their family. The purpose of the concept of long-term care that is many people-oriented, community-based, and provide continuous care service. Okay, you saw you can go to community care B and C, part in the course of delaying dementia and disability. However, after diagnosed dementia, there are 4 items the care service include long-term care service and transportation, respite service, rental, and purchase of access device, and improve a home barrier-free environment. Among them, home-based service include home social service, home care, professional service, home barrier-free environment improvement service, assist device service, community-based service, a lot of. Yeah. This process is regularly evaluated by the case manager of Unite A, and appropriate resources are referred in an interim manner, so that the mentally ill and the family caregiver can obtain continues the holistic service. The 18 service, 10 for people with dementia, 4 for caregiver, and 4 the medical care. At the August this year, total 680 units A and 7,191 units B and 1,322 units C have been constructed. We talk about the home care. I like to under the community-based care, I like to show you a story of my client. Yeah. Her name, we call her Miss Teacher Wang. Okay. Her name is Miss Wang Huaiyi. Yeah. She was diagnosed with dementia, Alzheimer's disease at the age of 89. Because of his care from Indonesia, could not cope the BPSD. So the family want to be taken, Teacher Wang to institution. After integrated assessment and individualized activity arrangement, daycare service was used for 7 years. Because she was a teacher, so we invite her come to our daycare center to teach English. And due to the age of 96, she was unable to come every day daycare because her food is not good. So we used the dementia care facility only 2 years. Finally, after 1 year, be buried in the nursing home of the Catholic hospital. So it's a sample. If we didn't have enough facility to the person with dementia, then we suggest them maybe they can use the daycare center at the beginning. So continue to deploy community long-term care institution. Yeah, 1 school district and 1 daycare center in Taiwan. That's the goal of our government. And you can see the slide. Yeah, from the statistics, it can be seen that growth of the daycare center, group home, or special unit of dementia may be a little slowly. That's why we maybe think about how to do. And the last part, we talk about the institutional care. There are 2,379 beds in Taiwan, but it's not enough for the people with dementia. So let me introduce our service concept of our Taipei St. Joe Alzheimer's Community Center. Our target is to create a loving home for the elderly with dementia, so they can live a more quality and dignity. Our mission is to provide our full service for the whole person, the whole family, the whole journey, and the whole team. Our care figure is individualized service centered on individual elder, multi-activity therapy, and family care and support, team care model, interdisciplinary integration. Like Teacher Wang, she likes to dress herself. So individual activities means whatever you like, you can do it. This is diversity activities. Yang benefit means just get some light outdoors, take a walk in the park. You can play mahjong too in our facility there. And we have diverse activities, complementary group activities, reminiscence or creative activities, and you spend, and then there are separated groups to go out, to go the room, the supermarket, or the, and we still have family support group. Last one is our government has some future plan, and we face the challenge at the same time. To establish a network of dementia-friendly neighborhood guidelines, and the second is it's not easy to obtain, to establish a new institution. So we look forward the active assist local government. The mayor maybe can talk about some non-profit organization, just like the third part is the number of group home, and the residential institution is insufficient, and the main problem is the cost is too high, and the staff not enough. That's what we have to deal with about this. And the fourth part, the currently 20 hours of training provided. Usually we provide 40 hours, but now only 20 hours. Lack of internship. And the second part is, it is recommended to maybe add advanced courses. In a public-private partnership approach to activity develop the diversified and comprehensive dementia care, increase the capacity of service for the dementia, improve the quality of life of the public, to delay the determination and the disability of the mentally disabled, and reduce the cost of care. That's my sharing. Thank you for your attention, and I wish you a happy Halloween today. Thank you.
Thank you so much to Mr. Jinyo Chen. Thank you. All right, ladies and gentlemen, the last speaker in the session is actually our moderator, Professor Guo. So let me introduce her to you. Professor Guo is an expert in geriatric studies, and over the years, she's gone out of her way to raise the public's awareness about dementia care and to increase dementia literacy. And she and her team have built one of the most comprehensive dementia care centers in Taiwan. And today, she's going to talk about the revolving door among hospitals, communities, and families, the dementia support networks and services. Ladies and gentlemen, please welcome speaker, Professor Zi-An Guo. Let's welcome her.
All right, I got a little busy, so thank you for introducing me. So I decided to call this topic a revolving door because for dementia family, they're really, really busy. You know, they might be going into the hospital one day, and the next day is they go to the community. And where do they go to services for in the community? So let me just quickly share with you some of the things as an academia person, and also I like to call myself a semi-clinical person to share with you what we have done in central Taiwan. And earlier, Dr. Bai from the south and Mr. Chen from the north, and I'm from the central Taiwan. So some of the things that we might have already covered, so I will skip. I wanted to first draw your attention to three pictures. This is a 56-year-old mother who loves flowering and crafts, and she is able to put up a very nice bouquet every single day, and she has been diagnosed with dementia for 9 years. However, nobody noticed that she has symptoms. The only way that the family member got suspicious was that because one day, being a volunteer mother at elementary school, she one time told her daughter, "I don't want to be a school volunteer anymore. I'm old," so that the young people take my stage. She used her old age as an excuse not to go to school to be a volunteer, but in fact, she knew that she had dementia or she was forgetting. Another case, those of you who are in the bioscience probably know what this is, even though it's a little crooked. It's a model of DNA. This was actually done by a biochemistry professor who had a misfortune of a heart surgery, and afterwards, during the recovery, he had a stroke and then eventually got into a vascular dementia. But she made this model at the dementia center, the community, to teach people how to understand biochemistry and the genes. All right. And then actually it turned out to be a very good exercise for a lot of people because you have to put A and T together and then C and G together so they're recognized by colors, and then they'll have to make correct DNA, otherwise it's going to be mutated. This is another case of a dementia person who is actually very young. And then so today I'm going to introduce you many of the cases who are really young, the young early onset dementia people. He was 48 when he was diagnosed, and with 2 children, aged 7 and 5. He was actually a very good engineer at the company, a superintendent in doing quality of service, quality of care. And unfortunately, he got the accident and then eventually got into diagnosis of dementia. He has 2 young children, and his father himself is also a person with dementia. So the only caregiver in the family is the wife, who really has to care for 4 people in the family. So all of these cases, if I didn't introduce the author of these things, you probably won't recognize, you probably won't think they are really people with dementia. Life is actually connecting dots. Sometimes it's a straightforward line, sometimes it's a very crooked line. This is a story that many of the dementia people told me. After they made this work, I asked them to give a signified saying of what this is. And one of the person with dementia told me, this is life, connecting dots. Seems so easy, but sometimes also hard for us. There are 300,000 people in Taiwan who are diagnosed with dementia, and then we increase it by 20,000 per year. And it's going to go on for the next 30 years. Of course, you know already that we have dementia action plan, and our director here today is very dedicated to helping us get to many of these factors. This is the 7 action plans, and Mr. Chen showed it earlier. So we have all these numbers, and then all over Taiwan, there are 22 cities and counties. There are many dementia centers and also support centers in the community. But more importantly, I wanted to also emphasize we also have a large array of services for caregivers. There are 2 national hotline toll-free number for people who can call. One is actually done by Taiwan Dementia Association, and another is done by Taiwan Family Caregiver Association. Many of their cases actually told us incredible inspirational stories that we wanted to dedicate to help caregivers. Our caregiver services, including relaxation classes, literacy classes, teaching caregivers how to take care of their loved ones, and we have respite, and we have also psychological counseling. We have care management for people who actually fall under serious caregiver depression or stress. And then so there are an array of services also included under the long-term care 2.1. And obviously we also have a dementia-friendly community that also sponsored by Department of Health Promotion. So Dr. Bai actually introduced 5 of the excellent services, and I also wanted to introduce a little bit of our services also in central Taiwan. I came from Taichung, and then I'm also a faculty member of Zhongshan Medical School. And then so the medical school affiliated hospital actually was the first dementia center established in Taichung. And before we established this center, I actually visited my alma mater, UCLA, which had one of the third largest dementia center in the United States, and learned of this model, a model for dementia and improved chronic illness care. We used the chronic illness management model. And more importantly, we want to emphasize that it is important that we have the collaboration of a professional team, and then we treated every single dementia person as a family, because behind every single dementia person, there is family member and also its support team. So we can't just look at dementia person as an individual. We have to look at it as a whole, of a whole community, as a whole family. So this is the model that we actually came up with, from health education to screening to diagnosis to treatment, and then to connect with long-term care. It's all in a one way, one array of services, one stop that does the whole thing. And then we do the connection for the family to get access to different array of community, home care, and also institutional care if needed. And then we actually accompany the case and the family caregivers. We divided into 3 teams: the medical team, the care team, and the resources team. For the medical care team, we had different medical professionals, and also we have traditional medicine and dentistry. For the care team, we had nurses, the pharmacists, the nutritionists, and all the rehabilitation professionals, including occupational therapy, physical therapists, and speech pathology. For the resources team, we had social worker, the psychologist, and one of the very interesting thing that popped up, we have the legal consultant, because a lot of dementia family are actually scammed, or they may violate the law without knowing. During COVID, for the past 2.5 years, that we were required to wear masks when we are outside, so many dementia family person didn't go outside wearing a mask, and they're fined. Seriously. So how could we actually come up with a policy to protect these people who can't really abide to the law, and then when they are getting into trouble because of their disease or their illness? All right, so we actually have this patient care center, and then with that professional team, we work with the community of different arena. Like Dr. Bai said, that in Taichung, there are 4 national arenas in Taichung: the National Opera House, the National Science Museum, the National Art Center, and the National Library, Digital Library. So we work with these 4 national centers and try to put up events there. When it was National Science Library, we asked that biochemistry professor to be there to introduce a lot of science models. He had dementia, but when it comes to biochemistry, when it comes to gene therapy and everything, he was like a natural. And so he gave a tour of the whole National Science Biochemistry department, and everybody was so surprised that, well, are you sure this person has dementia? When we went to the art museum, we had some people with dementia who wants to be artists. And then so they were there teaching the audience, the public, how to make calligraphies, drawings, and things. Make them be the teacher of our public. So this is something that we have done in Taichung City. And then this is our team. But still, with so much effort already, dementia is still labeled, is still with a lot of stigma. Sometimes even the closest members, family members, who think themselves as incapable of doing anything. A lot of our clients, they say when they're home, they wanted to help home chores, especially women. They wanted to help cooking. They wanted to help with dishes and things like that. But they forget which dishes are already being washed and which ones are not washed. So, they were actually scolded. The children, their mother-in-law might say, get away from the kitchen. You can only be a mess. You can only make mess. Stop helping us. As long as you don't do anything, that's already helping us. So they think that they are being treated as person without any capability, and they are being looked at very dumb. They sometimes are cursed. And so it's still happening in Taiwan as the world also. So we started to try to educate people based on this myth or this stigma, and try to tell people, a lot of myths that people still think that earlier when Miss Barbino said that there are 85% of people still think that dementia is part of, forgetting is part of aging. It's natural. You know, even the highly educated people think that, you know, they won't get dementia because they're highly educated. You know, and sometimes in our culture, some people think they are temporarily insane. But must be some kind of weather or some kind of curse. So they go to the temple, they go to the church and pray and pray and pray and think that, you know, the dementia will be cured. Okay. So, and sometimes their family member think that they are doing it on purpose. My mother is just doing it on purpose to forget things so that, you know, I can serve her. You know, I don't know where to put my things, my socks, my things. And then so they always said that my mother is doing it on purpose, trying to work me out. You know, I'm the least favorite child. So that's why, you know, she picked on me. And then when she was with my brother, she never forgets. But why with me and she forgets? You know, so all this myth that we try to educate the family members in their part of the disease and how to communicate and not to blame on the disease. All right, so with that, I wanted to show you some of the beautiful pictures. In Taiwan, we have a lot of foreign workers. And every time I see this picture, I feel a little sad because all 4 older adults are facing one way and the foreign care workers are facing the other way. Why? Sometimes I feel the foreign care workers need a break as well. I don't blame them for having to talk to their cultural, you know, people, their peers, because they need a break. But what about these 4 older adults? Can they be somewhere being taken care of and having fun instead of just looking at, I don't know where looking at. So for the community center that we have established, official name is called Support Center for People with Dementia and Their Families, done by Department of Long-Term Care, part of the Long-Term Care 2.1. There are more than 500 support centers. So I coined this thing as, you know, it's a center between the medical and the long-term care. It's a center between home and community. And then so this revolving door from home, you know, every patient and the family member can get to the dementia center. They can refer to use different dementia services. So what is the support center for people with dementia and their families like? There are about 550 of them in Taiwan. And then they do counseling, referral, they do congregate meals for people with dementia. Family member can join as well. They have classes and activities for people with dementia. There are family caregiver classes, family caregiver support groups. And also sometimes if a family member has to leave temporarily, they provide safety monitor for people with dementia. So let me introduce this very proud center that we have helped established. Okay, and these are the sample of the classes that we provide. Maybe not too different from what you understood, but I think it's very creative when it comes to class designs and things like that. And here are some of the samples of what they have done. From Monday to Friday, there are classes in the morning and in the afternoon. So I wanted to show you some very beautiful pictures of the people who are in the support center. When I used to show these photos, a lot of people would say, wait, who are the clients? Who are the volunteers? Who are the family members? Who are the workers? You know, we try to make it universal and equal. Over here, you can't even recognize who's who because we wanted to reduce stigma to the least. So this is a tour to the National Science Museum, which the center is nearby. We do very interesting exercise, try to do it outdoor as much as possible because they tend to be so much indoor already. You know, we try to do things outdoor. And then this is like a home living room. In the afternoon, when people don't want to do activities, we play game cards. We serve tea. Every dementia person or every client has to be on routine. They take turns, serve tea, and then we help them make different kinds of tea, whether it's a jasmine tea, a black tea, or sometimes very exotic tea. So we constantly ask for donation for different kinds of tea so they can introduce the audience different kinds of tea every afternoon. yoga, which is atypical of, of a dementia center. And then something I wanted to show you. In many times we think that a person with dementia cannot handle knives or scissors because they are dangerous. However, for a lot of women who, for their whole life, they're used to sewing and things like that, they are so good at doing crafts. So why not customize and individualize what they can do, and then let them be very proud of themselves because they are proud of what they can do. Okay, so as long as we hold our hands together, I think this is their slogan. They wanted to hold their hands together so they can accomplish everything. And then besides this, some of the concept that really inspired us was because we wanted to start seeing every individual very differently, the uniqueness in everyone. And this was actually inspired by a dementia advocacy action plan from the WHO. We wanted to see everyone equally with equitable resources and with justice. And obviously we were very influenced by Kate Swiver, who came to this country for 3 times already. And earlier Mr. Chen said nothing about us without us. So we wanted to ask them, what do you want to do? You want to do carving? You wanted to do singing? You wanted to go outside exercising? We try to give individual their plans and then their choice for doing what they want to do at the support center. And then and wanted to tell the family member, see the person, don't blame the person. If you need to blame people, blame on the disease, not your family member. And then so we wanted to bring advocacy and human rights to the highest level. And then obviously Taiwan did a very good job trying to unite all the judicial and the government entities to get involved and then try to actually make dementia a humane and with dignity an issue. So lastly, I wanted to share with you the training, the next generation. We all worry that the resources, the human resources, are not going to be available for all of us if the dementia is increasing at such a speed. Who's going to help and then take care of the people with dementia? So being at a university and as a professor of gerontology training and also a person in charge of medical humanity, I decided to come up with a project 3 or 4 years ago to train the next generation. And being in a medical school, I think I have advantage of actually influencing so many different departments, whether they are in medicine, nurse, psychology, OT, PTSD, and radiologists, or health technicians, or information scientists. So, and the reason why I wanted to start actually educating the young people is because I read a report in the United States that the millennials, meaning that people who are born after the year 2000, so they are in a college age, before they turn age 35, 1 in 6 millennials is going to be a dementia caregiver. Can you imagine we are starting to create a generation of young people before they get to work, before they succeed in their profession, they have to be a caregiver for many, many years first. And sometimes that actually happen in their 20s or early 30s. And what's going to affect their career projection in the future? So time's up, so I'm going to quickly introduce you to you. This is a project that I dedicated myself very much into. From the school, we can start educating the young people how to care for dementia and how to pay attention to the awareness of the increased number of people who are just in your neighbors probably. And then students started coming back to me and say, you don't have to say more. My grandmother had dementia. Another person said, my grandfather had it. And then I was so surprised when I had this workshop, about 90 people register in my university. And I was thinking, what the heck, the 20-year-old college students, why would they register to be in this workshop and then be interested in dementia? It turned out that 47% of the 90 people who came to the workshop said they had somebody in their family who had dementia. So it's starting to influence or getting into the young people's mind. All right, so I gave them some classes, teach them, understand dementia, how to recognize a person had dementia, what can we do for family members, and also what can we advocate, for in a community, and some of the resources they can do to help others. And it has been 5 years, 13 different professional majors with 560 students participating in this social advocacy workshop. And then students accompany our dementia clients to art museums. And by accompanying them, they recognize or they're aware of, wow, dementia is not as difficult as I thought. There were a lot of myths that young people, one student said to me, I never know that dementia person can talk. Wow, because the grandmother at home never talked. So, having to see that if they're in the natural, right environment, they can be as free as themselves as possible. So these are some of the fun events that we did together. And then caregiver workshops, and then the fun walks, and at the museum, as we showed earlier. And then and the library, So we work with the 4 national entities, and then we establish many support centers, and one being the early onset support center for dementia. And students get to observe and then play with them and also design activities for them. And then here's the results. It's very significant that before and after students participate in having just to spend time with them, increase the awareness of dementia and then increase the attitude, positive attitude of helping and serving dementia. And many of them said they would like to start studying more about dementia, and then perhaps when they get into the professional field, they will try to choose dementia as their concentration or special skills. And then also produce many action plans. Some of them are very, very fun. Together, they did friendly community advocacy. They try to reduce the stereotypes. They try to increase literacy. They try to do materials for the caregivers. And then here are some of the things. Students' reflection, communication, tech special skills for people with dementia. Prepare me to be a good doctor, having involved in spending time with the people with dementia. Never forget that the caregivers are important. Listening to patients is so important. I never think they can have such soft side, because they always see the aggressive side. I'm sorry. And then know how to interact with they know how to better interact with their family member. So these are student reflections. So at the end, we always had fun. And then more than 40 Facebooks, Instagrams, and Line ads together reach out to 250,000 people as a way of the 5-year plan for encouraging the students to get involved with dementia work. So at the end, I think this is my final stage, that I wanted to use the word of a dementia person who said, we forget and we make mistakes, and we do feel sad sometimes. But if you give me things to do with kind reminder, I feel I am still alive and can be someone useful. So let's try to let them be someone useful and then work together. Thank you very much.
Thank you so much to Professor Tzu Guo for her talk. And yes, Professor Guo, please join us on the stage for the QA and panel. Thank you again. All right, next we are going to have about 10 to 15 minutes QA. So if you have any questions, feel free to raise your hands later. And before asking questions, please make sure that you identify yourselves. And people online, you are also welcome to leave your questions or comments online. Thank you so much. And people here, please also make sure, if you're not talking, make sure that your mic at the chair is off, so that there won't be any noise or buzzing sounds happening. It's going to make it very difficult for interpreters to do their job. Thank you so much for your cooperation. All right, now, yes, the chairs are ready. So now we'd like to invite our moderator and also speakers to join us on the stage. Professor Guo, Professor Bai, and Mr. Chen. Please take your seats on the stage. And over to our moderator again, Professor Guo.
All right, so it's exciting to have this session. Does anybody have any questions or anything that you would like to share? Okay, I have a gentleman here. When you ask your question, can you just self-introduce yourself, maybe where you're from, please?
Yes, thank you. My name's Jack Niedenthal. I'm the Secretary of Health from the Marshall Islands. 3 quick observations. One is, I think you're the romantic one. Secondly, the one thing, I thought your presentation was just outstanding, and the one thing I'm getting from this whole conference is the way people in Taiwan and the government in Taiwan, they identify problems, and the way the society focuses on it so hard to correct the situation. It's like nowhere I've ever seen. I wish where we are, I could make people do that. We do pretty well, but nothing on this scale. It's really extraordinary. I think the government of Taiwan and the people of Taiwan really are fantastic. And I'm not saying that just because I'm sitting here in Taiwan. And the third thing I'd like to say is, I've been in the Marshall Islands for most of my life, over 40 years, and the one thing I've noticed, I remember very early on living on an outer island, and I saw this old man, and the whole family's been taking care of this old man, and he had obviously dementia. And I said to them, I said, wow, that's quite an obligation your family has. And he looked at me like I was something wrong with me. He goes, it's not an obligation. It's an honor to take care of this old man. He took care of our family his entire life. And what I find interesting is now there's this huge out-migration of Marshall Islanders to the US. And one place they've found where they get hired very often and are in high demand are in nursing homes, because they've been taught all their lives to treat older people with a lot of dignity, whereas a lot of Americans, when they're working in these nursing homes, they treat these old people like they're a sack of potatoes or something, whereas these young Marshallese people have been, all their lives, they've been taught how to treat old people with a lot of dignity and respect. I just thought I'd add those comments. There's no real question there, but thank you for those presentations. Very good.
Thank you. You wanted to respond to anything? Yeah? All right. Yeah. All right, over there, please.
Hi, my name is Victoria Fan. I'm with the Center for Global Development in Washington, D.C., but I was also at the University of Hawaii, where there's also a dementia issue as well. I just want to thank the speakers, just echoing what Jack just said, that a tremendous amount of work. I think the ways in which you presented the whole of government approach to tackling these issues is just amazing. I think the U.S. has so much to learn from how you're addressing these questions. I just have a couple of very technical questions. In the United States, we don't have an integrated health record system. It seems like doing integrated care would require some type of a common shared electronic health record system. So I just want to confirm that is a core piece of the medical specialties, as well as presumably, do social workers also have access to health records? That seems like a basic question, but in the US, we can't even get doctors to share records for the same patient. That's a huge problem. And then the second question I have is, because I'm a health economist, I'm really concerned about the resources. So how do services get paid for? How is this being paid for? Is it through the National Health Insurance, or are there separate funding lines through the ministries of health, through the long-term care? And then is there like fragmentation in that? How is that working? Are there plans to try to integrate the sort of financing and the payment? And even thinking through it sounds like there's this sort of community effort and community coordination. Are there plans to try to integrate that into the National Health Insurance, or is it sort of a parallel funding stream? And how does that affect the quality of care potentially? So those are my two big questions. One is the data systems, and then two is the payment system. So thank you so much. It's just so inspiring what all of you are doing. Actually, one last comment I will say, I had a student at the University of Hawaii. She was about to drop out of the program. She told me she had to go take care of her grandmother who had dementia, and I realized that this is going to be a big challenge for more and more people. So many thanks to you all.
All right, for the health record, how can we share, or do we have any kind of integrated system so that people can understand, you know, where our clients are treated and things like that? Dr. Bai, you wanted to say something about this? Okay.
Okay. Before the program of Centers for Integrated Dementia Care, several university hospitals, we have a dementia research center. So we have already a dementia registry program in each hospital. So we have medical records, but we did not have the connection to social resources at a time. But after 2017, we have a care manager. Care manager have two kinds of care manager. Care manager, one kind is from long-term care services. The other is from dementia care. Basically, dementia care, my hospital as an example, actually is working in hospital. So we work together. So we can easily combine the two systems together. So each patient may have medical record, and their need to be connected to social resources can be easily cooperated. So this is a way we have our data.
Okay, for a more macro question of whether it's fragmented or not, obviously to be able to do the 6 action plans under WHO, you need many departments to coordinate together. Like today, we have the Department of Long-Term Care, we have Department of Health Promotion and Bureau, we have the Department of Family Care Services. I must say that, of course, it's fragmented. You know, it's such a big, giant work that we all have to do. Otherwise, then WHO didn't have to put up all the 7 action plans. But we try as much as possible, like earlier the gentleman from Marshall Islands said, we have to really work hard. And then our advocacy groups is strong too, you know. So sometimes we do actually fight with governments, you know, try to point out with the government, to the governments that, hey, maybe from, you know, from our first hand, from, you know, working in the community and doing it in the direct services, we found so many problems. But here I like to say that our government people, actually, there are many of them here, Director Zhu Jianfang here, and then our health promotion leaders here. Sometimes I'm also a person who makes noises and be a troublemaker in front of them. But when it comes to working together, there's always, you know, platform for communication. And then sometimes, you know, I'm pleased with what I advocate for, sometimes I'm not. But together, I think we accomplish one by one. So I think it's a long process. And then deep inside, I think I appreciate with other government entities to try to listen to the first frontline workers, and also to really listen to the family members and try to come up with a compromise, I guess. Nothing can be perfect, I think. But thank you, Mr. Ms. 朱建芳司长 and then 国健署的这个长官, really hard work they have, yeah. And they don't have a lot of staff, so they really work really hard, yeah. So, would you like to say something, 司长? No? Okay, yeah, all right. So, any more questions? And also, I wanted to actually add one more thing. Dementia, there are professionals like, you know, Dr. Bai, the medical part, and there are the social part. I think what's very difficult is to integrate the medical and the social. Yeah, we have a very comprehensive health data under the National Health Insurance Plan, but we don't have a lot of congregated social data. And sometimes because of privacy, it's really hard to combine the two. It is also a problem, yes. But we try to solve it as much as possible, I guess, yeah.
Can I just follow up on that question? I mean, so my question is sort of more specifically on the role of national health insurance. So the centralized payment function really makes the data centralization very easy. For the social work function, is there who pays for that? Is that like a different If that's not NHI, that's presumably paying for services.
Yeah.
Social workers don't bill NHI, for example. In the US, there's kind of a trend to doing more of that.
Yeah.
So it's an interesting.
For the medical services billed by the health insurance, for the social services, the support groups and all the counseling, when it falls under long-term care, is the Department of Long-Term Care that pays for it. So we have, you know, this other, it's work under the long-term care asset money that we have. It's tax-based. So, and then another is social insurance-based. Yes. Yes, 还有 family bureau as well. Yeah. Social. Yeah. Okay.
So we actually have one raised online, but it's
okay.
it's more about how is it that Chinese medicine can be used in dementia care? How does it work?
Okay.
It's okay?
Yeah, there are many hospitals, I think, also have the Chinese medicine division. Sometimes some of them work. I know Dr. Bai doesn't want to answer that.
I have no idea.
You have no idea?
Sorry.
Okay. Maybe I can speak a little bit. I have a client who tried both at the same time, and she thinks it's the best of two worlds, because some of our family members, they don't want to take too much Western medicines, because I don't know if it's a myth or anything that we tried. Many families think that, you know, taking a lot of medicines actually hurt your kidney or liver, so they don't want to take too much Western medicines, especially sleeping pills and things like that. But then they were able to access Eastern medicine at the same time using acupuncture or some of the drinks, natural herbs, to help them relax and sleep. So, but then they do also take dementia medicine as well. So some of the family members are able to create or combine the two. I don't know if it's a good thing or not, you know, I'm not a doctor, but they are able to balance taking care of their family loved one and their own insanity at the same time. You know, sometimes they just use Eastern medicine as more relaxation and reduce the anxiety and things like that, and use the Western medicine to treat dementia itself. So they say it's the best of two worlds. Yeah. So.
But I think evidence-based medicine is very important.
Yeah, that's true.
But it's my personal impression that to have a very good dementia care, three things are very important. The first, our people must have humanity about dementia. It means to treat a person as a person. Yeah, it's very important. So you will emphasize the true human, even they have a dementia. So at this level, we can produce voice to give pressure to our governments. Then social resources were produced. Like you make noise. But I think most important is for doctors to make a good diagnosis. I dare not say correct diagnosis. It's very difficult to make a good diagnosis at the right time, because a correct diagnosis is the first step to dementia care, to set a plan. But unfortunately, it's very difficult to make a diagnosis, even patients step into your clinic. This is not only for Taiwan, but also in many Western countries. So this is the next step we need to face. It's a difficulty. Yeah, thank you.
Yeah, I've known Dr. Bai trying to tell all the doctors to be good doctors, try to make the diagnosis more precisely for many years. He is actually the champion, so yeah. All right, any more questions here?
Yeah, if not, that's actually all the time that we have for this
all
session,
the time
Professor
we have.
Guo.
Okay,
Yes.
all right, so let me just thank all the people who spoke, and then also thank the audience for coming to our session. And also, I don't know if there are any family member of dementia family clients or people who take care of dementia family member before. If you're a caregiver or ever be a caregiver, let's also give them a round of applause. And also, I wanted to lastly thank our government for sponsoring this session. Long-term care in our country is a huge duty, and then it's not easy without all the government people. Can you all stand 的政府的官员，让我们跟你们致意一下好吗？我们的朱建芳司长， 还有我们的国健署 ，Yeah, the health promotion， 还有社家署 ，Yeah, all three of them working hand in hand together. Thank you very much. And let's give all a round of applause. Thank you very much.
And thank you to our moderator and 2 speakers. Thank you so much. All right, ladies and gentlemen, we're going to have a break right now. We'll take a 10-minute break, and we'll be back by 3 o'clock Taipei time for the last session of the 2-day conference. So let's have a break. We'll be back by 3 o'clock. Thank you. 各位贵宾，那接下来呢，我们短暂休息一下，等一下3点，请各位贵宾呢再次准时回到会场，谢谢。 Ladies and gentlemen, we'll begin in 2 minutes. Thank you very much. 提醒各位贵宾，我们在2分钟之后正式开始，谢谢。All right, ladies and gentlemen, welcome back. Last session of the 2-day conference, ladies and gentlemen. Having talked about public participation and also infrastructure technology for promoting health and well-being for all, now, lastly, we'd like to bring your attention to collaboration and partnership, especially during health crises. And to moderate this session, ladies and gentlemen, please join me in welcoming Dr. Baozhong Chen, Distinguished Professor, Institute of Environmental and Occupational Health Sciences, College of Public Health, National Taiwan University, to the stage. 接下来我们是掌声欢迎场次的主持人，国立台湾大学公共卫生学院环境与职业健康科学研究所陈宝忠特聘教授为我们开场，掌声欢迎。Let's welcome Professor Chen.
Good afternoon, everyone. I think it's my pleasure to moderate the last session. I think the last should be very important, always. Because why? Yeah, I think this session entitled "Collaboration in Health and Well-being Crisis." As you know, during the past 3 years, COVID-19 pandemic, I think everyone knows how to get the more collaboration, not only global, international, national, also the local, even the individual in your community, how to get the more collaboration together to reduce the human risk, especially for we call the public health crisis. So I think the COVID-19 pandemic affected all the areas of the health and the well-being. I think it is not only public health crisis, also social, economic, even the political crisis. So lessons must be learned to ensure that the future public health crises are met with the resilience, unity, equity, So I think today we have the four distinguished speakers from the United States, from the European Commission, from the European country, and the last speaker from Taiwan, and share each other experience, especially in the COVID-19 pandemic issue. I think after that, if you have any comment or question, welcome. We have the 15 panel discussion end of the after the four speaker talks. So I have first the speaker from the United States Department of Health and Human Services. And also the second speaker, from the European Commission, also will give it the European Union health priority and the cooperation in terms of the crisis. And the third speaker from the Switzerland, I think she's a very important person. She's CEO of the World Federation of Public Health Association, and also the professor in the global health. The last speaker from the Taipei Veteran General Hospital, she will talk the COVID-19 pandemic, how works in Taiwan, and how to get the good the result in Taiwan. So let us start this section. So first the topic is the lessons learned and the new avenues for cooperation in emergency response. The two speakers will use the online the talk. So the first speaker is Mr. Jesper Lemana. She's current director of the Readiness Division at the U.S. Department of Health and Human Services since July 2008. She has also served with both the Navy and the Air Force. So let's welcome Mr. Jesper Lemana. Welcome.
Thank you and good afternoon. My name is Joe Lemana, and I am the Director of Readiness for the Administration for Strategic Preparedness and Response, or ASPR, within the U.S. Department of Health and Human Services in Washington, D.C. I want to thank the Ministry of Health and Welfare for inviting me to present today. We value our ongoing collaboration and hope that partnership is one that will continue to grow. The last 3 years has seen challenges to public health and public health emergency response not previously seen in our lifetimes. These challenges have forced us to adapt to meet new threats. Though most agencies responsible for public health emergency response are domestically focused, as they should be, however, connections with partner agencies abroad is essential for success as we go forward and continue to navigate future challenges. These connections are important to be able to exchange information, share best practices, and respond to public health threats that cross international borders, requiring technical collaboration and coordination between agencies. This is something we should do proactively prior to emergencies, because it's frequently observed, whether at the local, state, territory, national, or international level, a crisis is not the time to be handing out business cards. The agency I am part of, ASPR, was established by Congress through the Pandemic All Hazards Preparedness Act, or PAPA, in 2006. The objective was to create unity of command. That meant consolidating federal and civilian health and medical preparedness and response functions under one agency. We served as the lead federal agency for health, responsible for helping communities prepare for, respond to, and to recover from disasters and incidents that affect the strength of our healthcare system. In this lead role, we serve as the principal advisor to the Secretary of the U.S. Department of Health and Human Services on matters related to federal public health and medical preparedness and response for public emergencies. Most of our mission is domestic, but since our founding, we have maintained engagement with our multiple international partners. This engagement facilitated our ability to navigate the early phases of COVID. At the start of COVID, I oversaw the National Disaster Medical Response System, or NDMS, within ASPR. ASPR utilizes NDMS to support public health and medical responses to emergencies. This mission of NDMS is twofold. First, to supplement state and local medical resources during public health emergencies or disasters at the request of a state. And the second is to provide a backup to support our Department of Defense and Veterans Administration during an overseas conflict. Across the country, almost 4,000 professionals serve within the National Disaster Medical System. When they aren't responding to disasters, these people are physicians and registered nurses, dentists, paramedics, and other medical and support professionals in whom we entrust our health on a day-to-day basis. When the NDMS teams are activated in response to a disaster, these professionals serve as members of NDMS, and they are ready to respond within hours of activation. They deploy to assist during disasters and emergencies, providing expert care and services in conditions that are often austere and challenging. These deployments are domestic, but NDMS deployed to BAM Iran in 2003 and Haiti in 2010 to support emergency medical responses to earthquakes. NDMS's first COVID mission was partnering with Department of State and Department of Defense to bring U.S. citizens back from Wuhan, China, and the Diamond Princess, which was docked in Yokohama, Japan. Fortunately, the Diamond Princess operation, we had strong established partnerships with Japan's Ministry of Health, Labor, and Welfare, especially their Disaster Medical Assistance Team Secretariat. We had started regular engagement 2 years prior to improve our abilities to support citizens during mass gatherings as Japan prepared to host the 2020 Tokyo Olympics. This partnership allowed for incredible coordination with our Japanese partner and was a key reason why we were able to accomplish the successful repatriation of 300 American citizens from the Diamond Princess. Our team had barely landed back in the United States when NDMS was called upon to support the disembarkation of over 3,500 passengers from the Grand Princess ship in Oakland, California. A significant portion of passengers and crew were from abroad, and we needed to work with our partners successfully to ensure their safe and timely repatriation. Again, our existing partnerships in and around the world allowed us to quickly engage and ensure successful execution of the mission of repatriating these individuals. The next 18 months of the pandemic significantly tested NDMS. All of our programs in ASPR, as well as a support to the country through our pandemic response. We were challenged, but we persevered, learned, and adapted NDMS teams supporting medical decompression missions, COVID therapeutic administration missions, and vaccination missions. Even during time with limited international travel and cross-border engagement, Taiwan took leadership, organizing virtual meetings through global cooperation and training framework, including one prepared for the second wave of COVID in 2020, which ASPR's chief medical officer was a speaker. This expansion of virtual engagement, sharing innovation is one of the positive innovations that come out of the pandemic. During 2020, the United States, we were fortunate to see a surge of volunteers in our Medical Reserve Corps, or MRC, which was created shortly after the events of September 11th, 2001, to establish local units of medical and non-medical volunteers capable of supporting public health needs in communities and assist in responding rapidly to disasters. MRC volunteers are not federal assets, and they are not directed or controlled by ASPR. However, ASPR supports MRC network by providing technical assistance, coordination, communications, strategy and policy development, cooperative agreements, training, and other associated services. During the first 18 months of the pandemic, MRC volunteers contributed more than 2 million hours assisting communities with COVID response. Volunteers did everything from screening and testing operations to medical surge support in long-term care facilities and healthcare facilities to community education and outreach. Recognizing the success of this program in 2001, ASPR received funding through the American Rescue Plan to strengthen and advance the MRC program. ASPR and our federal partners made significant advances in innovations in healthcare delivery with the establishment of the National Emergency Telecritical Care Network, or NETSN. NETSN expanded the reach of critical care specialists and qualified clinicians to areas where they were needed without having to physically be deployed. Caregivers in the continental United States could monitor and provide care to patients hospitalized in Guam, 6,000 miles away. This platform and similar technologies have the potential to expand international partner support across borders. Starting in 2021, a vaccination began to be more widely available. We started engaging again with our international emergency response partners, sharing lessons learned and looking to future threats and events with updated thinking from our COVID-19 experience. With Japan, we conducted a virtual 5-part tabletop exercise, reviewing the lessons learned from the Diamond Princess and the Grand Princess operations, and working to facilitate better, strong future collaboration. We've had information and productive meetings with our partners and in Taiwan on our experience supporting medical response in the Pacific Islands and the potential to further collaborate going forward. ASPR in Canada continued to have monthly engagements, sharing and discussing lessons learned from COVID experience and how we can prepare for future threats. Some of the opportunities going forward include sharing best practices and lessons learned from our COVID response, ensuring the ability to exchange information about future threats and events between technical experts and responders in an efficient manner, using virtual and telehealth innovations to potentially enhance mutual support across borders. While in-person training and meeting is valuable for establishing strong, resilient relationships, the expanded ability of virtual engagement between emergency response partners has allowed for significantly more cost and time-efficient engagement between partners. We continue to face an array of natural, technical, and human-caused threats and hazards, including natural disasters, infectious diseases, seaborne threats, cyber security threats to healthcare systems and infrastructure. Partnerships can help individual countries and regions improve healthcare resiliency, ensuring that a healthcare system will withstand times of stress and will continue to be accessible under the most difficult of conditions. COVID reminded us that we don't respond to these events in a bubble or individual countries. Partnerships are essential to ensure we get the best lessons learned out of previous experiences and are ready for future threats. As Minister Sheway observed in opening comments, despite the continued challenges posed by COVID and future threats on the horizon, freedom and end openings, respect for diversity. Again, he observed in the opening remarks yesterday, a friend in need is a friend indeed. This pandemic impacted all of us. Going forward, partnership together, sharing our expertise, lessons learned, and plans for the future, we will be able to move forward effectively. Thank you for listening, and thank you to the conference organizers and my fellow presenters.
Let's give him another big round of applause. Thank you so much.
Let's move to the second talk in this section, entitled, Should We Still Talk About Crisis? The second speaker, Professor, the second talk it should be the EU health priorities and the cooperation in time of the crisis. The speaker will be the Dr. Isabel de la Mata. Dr. Isabel de Mata, a graduate in the medicine and surgery by University of Basque Country in 1983, and holds the postgraduate degree from the University Louvain and Paris in public health. So she's a specialist in preventive medicine and public health. He's currently he's the principal advisor for health and crisis management in European Commission. So let's move to the European Commission, how to deal with the public health crisis. Welcome, Isabel. Thank you.
Let's welcome Dr. Isabel de la Mata. 掌声欢迎。We have Dr. de la Mata online with us? No? She's a no-show? No? So should we wait for her, or we should move on to the next one? Sorry guys, just give us 1 minute. Yeah. We're trying to figure it out. All right, we're sorry. We probably will need some more time, so can we have our moderator introduce our next speaker first? Okay. We're sorry about that.
Yes, let's move to the third talk. I mentioned before, should we still talk about the crisis? Professor Bettina Borish. She's a medical doctor by training in clinical pathology before she moved to the public health. And she's the global public health expert. She has a long experience in collaborating with the international organization, both at the UN level as well as the European level. Currently, I think it is very important. She is the CEO of the World Federation of Public Health Association, and also a professor at the Institute of Global Health, University of Geneva. As you know, I'm also the president of Taiwan Public Health Association. So I remember the 2011, I go to the Geneva to join the World Federation of Public Health Association. I think it's very important how to, even we are a private association, we try to get the more cooperation and the communication with each public health association in different countries. Yeah, welcome, Bettina.
Please welcome Professor Bettina Borish.
Thank you very much. Good afternoon. Can you hear me? Good. Thank you to all my Taiwanese friends to have invited me. Thank you to my international friends and colleagues to be here and online or in presence. I am honored to be here. And I would like to say that this time when I traveled to Taiwan, a country that I admire, I was especially grateful to be able to travel without restrictions. And I don't think only of necessary sanitary restrictions, but I also think of the fact that I can travel from a free democratic country to another free democratic country. A privilege that is not granted to a lot of people in this world. And I think it should not be a privilege, because it's a human right to be in freedom. This being said, I should start with a big slide of conflict of interest. Why? Because I have a serious conflict of interest that is that I am a friend of Taiwan, and a very, very long-standing friend, and I admire, and every time I come, I learn more. In the previous session, I learned about the amazing things that you put in place on dementia. So, this being said, I want to invite you not to data from my academic work, but to talk about how we use words. And I think it's important to know when we use words what we mean. And I think we heard the word crisis a lot these last 2 years and also these last 2 days. So what does crisis mean? Crisis is a Greek word, ancient Greek. Here you see it written in Greek letters. And at the time in ancient Greek, it meant different things from what and how we use it today. At that time, it meant decision, back. It meant decision, determination, judgment, but also trial, sentence. So sometimes quarrel, dispute, and also in the medical field, the time when a disease decides to go for the better or for the worse. So nowadays, we have a completely different framing of crisis. I looked it up in the Cambridge Dictionary, and the Cambridge Dictionary says, crisis means the time of great disagreement, confusion, or suffering, or it also talks about a point in time where there are difficulties. So this frame leads us to think that crisis is a short, bad moment that we can go through and then it's over. And there's one single bad moment. We just have to go over. I think this framing not only works in our brain, but also determines our activities. And that's why I would like to challenge this, because crises are not one single. They tend to cluster. Crises very frequently come all together. Not only today we have the feeling there are a lot. Think of the year 1961. 1961, several wars were going around in the world. Vietnam, Angola, to mention some. But also for Europe, something absolutely unpredicted happened. The city of Berlin was separated by a wall into 2 parts, and citizens of one city couldn't visit each other anymore. And there was the USSR trying nuclear weapons, and Fidel Castro, and the Cuba crisis. And people were imagining that they could be the Third World War. And second thing, crises only have an apparent beginning and an end. If we look carefully, each crisis had already preliminary signs, and there were preludes to the crisis. And the same holds true for the end. I think you have heard, as public health and health people, the question, is the crisis over now? Is COVID finished? I think that every crisis has important sequelae that go on for society, for economy, and sometimes they reach out so far over decades that only historians will tell them these were the things that the crisis had as impacts. Think of another important health crisis, an old one, the Black Death. In Europe, the Black Death in the 14th, 15th century killed millions of people. If you take only France, then 40% of the French population died. That means that in France and everywhere in Europe there was serfdom. Workforce was there abundant and you didn't have to pay workforce. Now, with the pandemic of Black Death, workforce became rare. Something rings a bell? Workforce became rare and you had to pay for it. You had to pay for it with money. And the people you paid for had money in their hands. They could buy important things like education. And then what was a consequence was the fact that besides aristocracy, there started to be a middle class. And this growing middle class, step by step, asked for rights and finally went up for a French Revolution. So I think we always have to look at the real long-term issues in crises. And lastly, crises sometimes really coincide, as we see with the nexus of the COVID pandemic and the climate crisis, and some people tend to call it syndemics. Now, question to you, have you heard about VUCA? VUCA is an acronym that stands for volatility, uncertainty, complexity, and ambiguity. This is an old term. It has been coined already in 1987 by Warren Bennis. He was an American scholar, worked mainly in leadership, and the term VUCA has been used by especially the military. But let's go and look at the elements of VUCA. VUCA, volatility, means the speed of change that seems so fast. Uncertainty means the lack of predictability, the insecurity, the surprise. Complexity, the multiplex of forces, the confounding issues, the weird fog around things, no real cause and cause effect that we can determine. Here's the cause, there is the effect. And lastly, ambiguity. Ambiguity says, well, there is so many misreads, misinterpretations, mixed meanings, no cause and effect. I think a lot of us have this feeling of all these four things nowadays, and that is why, and I make a little cut here to invite you to our Rome Congress. We called our Rome Congress of the World Federation A World in Turmoil. But you see that the subtitle is more optimistic, opportunities for the public's health. You're all warmly invited to come to Rome, May 2nd to 6th. Having said that, let us turn back to crisis. How then should we handle crisis? In our mind, the one little thing, I think it's impossible to tackle one thing after the other, to say, I'll handle one crisis after the other, done, as I would do in a business model. And also what I hear a lot is the back to normal. Simply, there is no back. We cannot go back. And if you look at normal, normal is a very difficult thing and changes when you start to define it. So I think clearly to believe that you can handle one crisis by one is an illusion. So what should we do? Some people say living with crisis. Yes, I think every one of us will have to, or has already, adapt to some very, very strong facts. Change is continuous, and there is not a single moment, a single crisis, and there is not a single rescuer. From the right-wing populists, we hear now the call for the one man that will solve everything. Forget about it. That doesn't exist. Even if these facts may, in the first place, be a bit frightening, but in the long run, getting the active attitude is salutary, really the only way. And I liked a quote that Fran Baum showed us. Optimism is a political act. I think we are condemned to it. And I think also in living with crisis, the flexibility and adaptability must be central to all crisis response. And there, I liked very much what the Hawaiian example from Victoria was, where she showed us that you can do planning and tell people this plan goes for the next 2 weeks, and then we will readapt. And it worked, as you showed us. This flexibility and adaptability is true for us as single individuals, but it is also true and much more difficult for whole communities, whole societies. And I think especially at the international level, for us as international community that we are here, because we handle global crisis, this is a real challenge we have to face. I'm working a lot these days with the pandemic treaty that has been mentioned very early on at the beginning, first day of the meeting by Martin McGee. And Martin talked about the pandemic and also about this treaty. This treaty will be a legally binding document, either convention or treaty, we'll see, work in progress. But the art will be to inbuild flexibility in such a treaty and to have mechanisms that allow for adaptation. And as odd as it may sound, only flexibility and adaptability will ever guarantee us stability. So if I come back to this VUCA acronym, if we put it into today's times, with the existence of global challenges that are closely related, what do we need? We need system thinking, already mentioned by Fran. We need vision. Even if there is a lack of predictability, we have always to know where we want to go. And we need understanding that all our acts have consequences, long-term, direct, or in other places. And then we need this adaptability to be ready for alternative realities that may pop up at the next step. So this sounds quite difficult. And indeed, as we have been acting until now, we will not make it. In a recent workshop on collective leadership, that was mainly run by women. I think not a surprise. There were some men too. We thought, what could be the new leadership? And we started to say, it must be a meaningful, sustainable solidarity style that enables us to move beyond existing world paradigms. Every world paradigm has to be put under scrutiny. May it be the nation state or the growth paradigm in economy, everything. And we need, and I think this point in time is at a doorstep and an opportunity to redefine leadership and promote a new leadership model. What we were thinking of was not necessarily the famous one deus ex machina, single man who saves the world. No, we were more thinking about groups of people put in leadership, or two people, co-leadership, because I think that movements, and that was also mentioned by Fran, changes come from people, from groups of people, and very frequently, sorry for the gentlemen, they come from women. It were the market wives in Paris who started the French Revolution. Historians have forgotten about them, but that is normal. And it is now the brave young women who started in Iran, and now the whole population of Iran is in the streets. So our leadership model, to describe it, we said, what do we need? And we said, let's put a job description for the leadership that we want to see to make the changes we have to do now. And our job description is as follows. Job description for new leadership. And always keep in mind, it can be who can apply, a single person, two persons, or a group. We ask these leadership to be able to travel beyond your own worldview. And then the skill to put this learning to others. You have to have the willingness to use new tactics and approaches and create spaces for others to use them too. And now comes a point that's very important to us, have the courage to acknowledge failure and receive feedback and lead with awareness. And the fourth skill that we think is important is the ability to be public-spirited, community-minded, and demonstrate that commitment with truth, reconciliation, and equity. So if we would put up this job description, I think most of today's political leaders would fail. They simply don't fit our job description. So we definitely not only need new leadership, but probably also learn with leading groups and leading people how to do it. So what should we do now? I come to say that definitely we have to abandon the current modus of operandi of approaching crisis one by one as discrete events with discrete solutions. And instead of that, we need a diversity of thought, flexibility, and adaptability as leading principles with a new form of leadership. In responding to the complex and interlinked global challenges, I think this is an important added value. Martin McGee had a list of things at the beginning, what we need to tackle upcoming crises, upcoming pandemics. He stopped at the point money. I would add the point new leadership. What to do now? Yeah. I come back to my initial question. Should we still use the word crisis? I think yes. Yes, if we use it in the Greek and also the Chinese term, where Chinese says it's danger and opportunity. Yes, and if we think it is decision and it's also judgment, then yes, we should use it, but not in the terms that is written in Cambridge Dictionary, which can shape our mind and our activities. But, and that's the last thing I want to say, the difficulty is that we are all in the flow of events, and we are at the same time part and actors of this flow. So in this, I would like to end with a quote from a German poet of the 18th and 19th century called Friedrich Hölderlin, who said in one of his poems, "Where there is danger, the saving powers will grow as well." Thank you very much.
Thank you so much to Professor Bettina Borisch for her thought-provoking talk. Thank you. All right, we sorted out the technical difficulties, and now we are going to go back to our second speaker in this session, Dr. Isabel de la Mata, Principal Advisor for Health and Crisis Management, DG Sante, European Commission. All right, Dr. de la Mata, are you here? Are you online with us right now? Yes. All right. But it seems like we cannot hear you. Please make sure that you have your mic on.
Yeah, can you hear me now?
Yes, loud and clear. Please.
Okay. Okay. Thank you very much. Thank you very much. And sorry for the technical problems that we had before. And I'm going to ask you to manage my slides because I had also some problems. So next slide, please. The European Commission has been working with all the members of all the state members of the European Union since the beginning of this COVID-19 pandemic, but also in previous years to try to contribute to make the health security stronger, not only in the European Union, but in the rest of the world. So we, as the European Commission, has a role of guidance of the member states and also the proposal of new legislation and also to control how this legislation is ongoing. Next one, please. I'm going, next one and next one, because as we were a little bit delayed, yeah, this one. So the COVID-19 pandemic has underscored the importance of coordination among the European countries to protect the people's health, both during a crisis as well as in normal times, when we can tackle underlying health conditions, invest in strong health systems, and train the healthcare workforce. The lessons learned during the still ongoing crisis have greatly influenced the current Commission's agenda in the field of health, which I'll summarize in the next slides. Next, please. In the wake of the COVID crisis, the European Commission has taken a number of unprecedented measures to guarantee the European Union citizens' safety and acknowledge the need to build a stronger European health union and step up investment in health system crisis preparedness. These measures are mainly focused to the European Union citizens, but not only. So one of our main concerns and one of our main areas of work is the global health, and we are also developing a global health strategy because, as it was already said at the beginning of the pandemic, we will not be safe until the whole world is safe. Next one, please. So one of our main area of concern to better prepare for the health emergencies. And this is what we have been doing since 2020, strengthen the European Union health security framework in order to reinforce the measures that we were already applying and to allow a better coordination. So we have reinforced our legislation. We're making a more robust mandate for coordination at the European Union level, and we have also reinforced the mandates of our main institutions, main agencies that are working in this area, that are the European Centre for Disease Prevention and Control and the European Medicines Agency. Next one, please. The proposal for a regulation on serious cross-border threat to health that since last week is already a regulation. I mean, that was already approved by the Council and the Parliament, and will enter into force short time, has several areas of focus. The first one is the preparedness and response planning. So we want to increase the health crisis and pandemic preparedness, also focus on the different interregional elements, coordination, the adoption of the national plans, also with reporting and auditing the preparedness, making even tests and exercises with the member state to see how things are going and to introduce corrective measures if necessary. And one of our main focus is the training of the staff, public health staff in the member states, so that we could do also knowledge exchange activities. And the joint procurement that already showed during the pandemic the importance and the value taking into account how it works for the procurement of vaccines, we are going also to reinforce that. Next one, please. So, but not only the preparedness activities and the response are important, but also the epidemiological surveillance and the establishment of new networks that could allow us to be prepared and to advance when something could be happening. This is why we need to strengthen the ECDC and how the European Centre for Disease Prevention and Control access to the health data for research and epidemiological aspect. And for that, it's important that the report increase the requirement. Also, we are creating a network of reference laboratories, EU reference laboratories, and also we are reinforcing the surveillance on the substance of human origin to support the transfusion, transplantation, and medically assisted reproduction. Next one, please. And finally, the early warning and risk assessment that we already have that, but we are reinforcing that area, the early warning, that is really very important. But we also concentrate in checking and controlling the medical countermeasures and the medicines. So advancing when there could be shortages that we could also reverse via cross-border emergency assistance among the member states. For that, we don't only count with the ECDC, but with all those agencies that you can see there, the Food Safety Agency, the Chemicals Agency, the Environment Agency, the European Medicines Agency, and of course, I didn't mention before a new authority, a new service that has been created during the pandemic, that is the Health Emergency Preparedness and Response Authority. Next one, please. The coordinated response at the EU level will allow that with the Health Security Committee, where all the member states are represented, to be able to adopt decisions, to adopt the guidance and specific response measures, and in that way also that we are able to respond earlier. Not only we need to wait for the declaration of an emergency situation and a pandemic by the WHO, but at the EU level we could also allow to declare an emergency situation of European Union concern. Next one, please. Apart from the response in cross-border health threats, we are developing other areas that could support us in this response to the health threats, in this support of health security at EU and at global level. One of them is the pharmaceutical strategy for Europe. We have a pharmaceutical strategy, but the last full legislation is from 2001, so we need to support the innovation and the reliability also of the supply chains, and for that we want to update. One of our main concerns is the access to affordable medicines for the patients and also to address the unmet medical needs. For that, the orphan medicines and the pediatric medicines will be two of the main areas of focus on this new pharmaceutical strategy. And as I mentioned, to address the security of supply, keeping the quality and the safety is our main concern. Next one. Another of the strategies that we have been developing is the Europe's Beating Cancer Plan. 1 in 3 citizens will be confronted to cancer in one moment of their lives, and this is why we need to support, to coordinate, to supplement the effort of the member states in the prevention, in the treatment, also in the diagnosis, of course, but also to improve the quality of life of the cancer patients and also of the survivors. And here we are coordinating the research, the innovation, the personalized medicine, and also one of the main areas is to reduce the cancer inequalities across the European Union in the prevention, diagnosis, treatment. And currently we are discussing a council recommendation on screening of different kinds of cancer, updating the recommendation that we had in 2003, and that at that moment we're focusing in cervical, breast and colorectal cancer, and now we are expanding to prostatic cancer and lung cancer. Next one, please. For all of those areas that I mentioned, one of the topics that are really important is the European health data space, the creation of a European health data space. So we putting in the center the patient and the access and the control of their own personal health data, but we need really, in order to advance, to create a single market at the EU level for all the digital health services. This is quite challenging because we need to coordinate the electronic medical record in all the member states that not always still exist, and also the access and the use for research, but especially for follow-up of the patients and treatment. And also we have, of course, the problems of interoperability, but it's something that the proposal was approved in May, and we are currently discussing with the Council and with the European Parliament. Next one. And finally, the concentration in the non-communicable diseases in general with a new initiative that is Healthier Together, and that is working on 5 different strands. Behavioral determinants of the classical health determinants, diabetes, cardiovascular, chronic respiratory diseases, but quite important is the 5th strand, that is the mental health. In the last year, and the contribution of the pandemic to that has been really important. The problems of mental health of the citizens has been increasing, and we need to address that, and we cannot continue ignoring the issue of mental health. Next one. To support all these ambitious set of policies, we have a funding instrument, European Union funding instrument, at the disposal of the countries. And the main ones are the ones that are marked, the EU for Health and the Recovery and the Resilience Facility. Next one. Zooming in on the first one, the European Union, the EU for Health program, 2021-2027, has put together the support to the EU response to the health crisis triggered by the COVID-19 pandemic. This is the largest health-specific program ever that ever has existed in the European Union, with an envelope of 5.3 billion euros that will be spent in these 7 years, 2021-2027. And just for you to have an idea, the previous program, that was 2014-2020, was 460 million euros. So we have multiplied by 12 the funding that we are dedicating to health. We will providing financial support for actions in these main 4 strands that are improving and fostering the health union, tackling cross-border health threats, improving the medicinal products and medical devices, and strengthening the health system resilience and resource efficiency. And as I said at the beginning, this is not just to focus on the European Union per se, but we are trying to take into account this global health strategy and this global health vision that we are not isolated in the world. Next one, please. And the other specific fund that I am going to mention briefly is the Recovery and Resilience Facility. That is one of the main financial instruments through which the European Union supports the member states. This is just more focused on the internal EU action and not in the global health, but we are supporting the member states to mitigate the economic and social impact of the pandemic, and mainly supporting the investment to increase the resilience capacity of the healthcare system that had been really very damaged during the pandemic, and supporting the health workforce that has been really very damaged during the pandemic. So we support the implementation of health system reform and the investment that had been agreed with the individual member states, with each of the EU member states, and these member states, the countries, have decided to dedicate a significant share of the recovery and resilience plan to the healthcare investment. Next one, please. And these are the main types of investment and reform that the European Union member states have included in the recovery plans. But what I want to mention is that there are 2 key aspects that are the human resources and the access to healthcare. So this is what we are going mainly to support. Next one. So I also wanted to mention that what is here, that we cannot forget what has been happening now that we are going better in the pandemic. We cannot forget what happened. We cannot just go back to the normal. We need to learn from that, and not only to learn from it. What we need is to work in order that this does not happen again, because otherwise, if we go back to normal, we go to the low investment that we had in public health, this 3%, classical 3% that we are dedicated to prevention, compared with the 97% to treatment. We will have another pandemic, we will have another health threat that maybe next time we could not solve. So thank you very much. Next one is just the last one. And very happy that you invited me to be present in this health forum. Thank you to you all.
Thank you so much to Dr. Isabel de la Mata. Please join us later for the QA. And now over to Professor Chen to introduce the last speaker in this session.
Okay, the last speaker come back to Taiwan, and Dr. Li, he's currently he's the Deputy Superintendent of the Taipei Veteran General Hospital. She's medical doctor training in internal medicine, and also specialized in gastroenterology. And also, she got the master's degree and the PhD degree from Johns Hopkins School of Public Health. So she is also the public health person. And welcome him to give us his talk entitled Public and Private Cooperation in Times of a Pandemic, Taiwan Experience. Welcome, Dr. Li.
Please welcome Dr. Wei-Chang Li.
Good afternoon, ladies and gentlemen. It is my great honor to be here and to present and share the Taiwan's experience in our public and private collaboration in times of crisis. I heard Dr. Isabel Mata talk a lot about the resilience, and I think I will show how Taiwan achieved our resilience from the past two episodes of pandemic. The first one is in the SARS in the year 2003, and this one since 3 years ago. Currently, I am Dr. Wei Changli. Currently, I am the Vice President of the Taipei Veteran General Hospital. It is one of the leading medical centers in Taipei, Taiwan. And over the past 3 years, this hospital and my colleague will work together with many other government and non-government hospitals to fight the COVID-19 and to save lives. Taiwan's performance in pandemic control has been highly regarded by the international society, and several contributing factors are widely recognized is the main key factors to our success. The first one is government, the proactive measures and the quick response. And second is a well-prepared and quick response medical system. And there also wide application of technology and innovations in our pandemic control. And we also thank our people because there's a wide public awareness and community engagement. But finally, I think the most important one is the public and private collaboration in many perspectives. Otherwise, we cannot achieve this goal. And we heard about the crisis. There's an old Chinese saying, we can turn a crisis to opportunity. I think actually the first time we drawing the right lesson from SARS outbreak in year 2003. At that time, we have about more than 300 died, unfortunately. So we learned from the experience. The government amended the Communicable Disease Control Act in year 2004. Not only the Infection Control Agency was reinforced in their functions, actually the collaboration between the government and non-government sectors and between the central and the local government were also improved and enhanced after the SARS outbreak. At the beginning of this pandemic in year 2020, the Taiwan government immediately launched the Central Epidemic Command Center, or CECC, to integrate the command, dispatch, and operation of various public departments from central to local government, and to achieve the highest efficiency and to avoid the inconsistency across the department. The CECC also plays another important role, is to mobilize the non-government resources and manpower to combating the COVID-19 pandemic together with the public sectors. For the past 3 years, Taiwan has taken very tight border control policies to prevent the COVID-19 infection from abroad. Before October 2022, actually this month, all arriving citizens and non-citizens were required to be quarantined for a week or longer. Moreover, nearly 7.6 million Taiwanese got COVID infection, and many of them were mild cases and were required to be isolated at a collective quarantine site, hotels, or homes. To avoid the community transmission and to assist these quarantined or isolated people, huge manpower and resources from the public and the private sectors were mobilized. The following, I will show you some statistics from our Taiwan CDC. Actually, even for many Taiwanese on site, I think maybe this is the first time for you to hear these very solid numbers. A total of 63 places and more than 7,000 beds were requisitioned by the CECC for collective quarantine or isolation use. Many of them are belonging to the central or local government asset. And over 130,000 people and 1.2 million person days were served, including their accommodation and their healthcare, security, and the logistics. At the same time, Here are we call the 防疫旅馆. Many private hotels were also encouraged to change their service models in times of pandemic. Up to 519 hotels and over 32,000 rooms were remodeled to serve the 880,000 quarantined or isolated with mild symptoms. And the community transmission risk as a result were significantly reduced because of the collective quarantine site and the hotels. But for the majority of the confirmed case, I think about 5 million of them were quarantined or isolated at homes. And their close contact, about 1.5 million were took home quarantine. It raised a public concern. Who will take care of these quarantined or isolated people at home? It is quite often that the whole family members were isolated. And especially for the many elders who live in the rural or mountain areas and who will take care of them during the isolation or quarantine period. The local government actually took this responsibility together with many private sectors. The life assisting service, as usual, include but not limited to the mail delivery, garbage collection, settlement, and family visit, and medical service arrangement by them. Actually, the quarantined or isolated people can get government financial support after the isolation or quarantine period. And moreover, there are many charity donations from the private sectors. Taiwan has a well-organized household system we call the 户政系统. And during the pandemic, over 7,000 frontline government employees were devoted to assisting the quarantine or isolated at home, including the 415,000 people coming from the other countries. We did not only assist their living need, but also took care of their physical and mental health. Both the central and the local government established hotlines to help the quarantined around the clock. The first caring center was established at the lobby floor of the Ministry of Health and Welfare on February 11, 2020. Over the past 3 years, over 400 volunteers, including nurses, psychiatric, and many other professions, they participated to the caring services, offering more than 230,000 phone call services. The 22 local government also established the similar caring centers. Up to October 2022, nearly 1.5 million phone calls were received from the 400,000 quarantined at home. The caring center can help the quarantined to arrange their medical and living assistance. So the next problem is how to fit their transportation need for the quarantined and isolated people. We need to appreciate for the taxi drivers. There are about 2,000 taxi drivers. They established a quarantine taxi team on March 4th, 2020, and pick up all arriving passengers at the international airport to quarantine sites or hotel back and forth. Similar taxi teams were also organized by the local governments. Up to the October 2022, more than 570,000 times were served. Some quarantine tracking systems were developed by our private IT companies and introduced by the public sector for pandemic control purpose. For example, a digital fencing system was introduced to track the quarantined or isolated at home. This system cannot work well without the cooperation of all private mobile phone systems in Taiwan. When an isolated or quarantined people ran away from the home or digital fence, an alert short message was sent to the local health authorities, and the authority will send officers to have a home visit within 15 minutes. The person, he or she ran away from the isolation or quarantine place will get a fine. The capacity and the efficiency of the PCR testing is a key to identify confirmed cases as early as possible and can avoid the further infection spreading. At the early stage of the pandemic, the total capacity for PCR testing was only about 80,000 tests per day in Taiwan. The government mobilized and supported the high-profile laboratories in Taiwan and the technicians to expand their capacity. So up to October 2022, nearly 266 laboratories can perform the PCR testing with a maximum capacity of 230,000 tests per day. This capacity is much higher than the historic peak of our maximum confirmed case. It's 95,000 on May 27, 2022. Face mask shortage was a worldwide issue at the early stage of COVID pandemic. Taiwan government called for a national face mask team in April 2020, and many textile industries stopped their original production lines, and the Taiwan's face mask daily production increased from the 1.88 million to 21 million by 73 production lines around the country after May 2020. So up to October 2022, a total of 3.4 billion masks were produced and rationed to our people. To let every Taiwanese have the equal opportunity to get the face masks, the government adopted a name-based ordering and rationing plan in times of mask shortage, and in 3 stages. The first stage, people need to wait in a long queue for the rationed masks at pharmacy store or the healthcare clinics or at the local government. In the second stage, people can get the pre-ordered face mask online and pick up at more than 13,000 convenience stores around the country. And in the third stage, after the mass production by the national mask teams, people can get the rationed mask much more easier, such as at the kiosks. The 75% rubbing alcohol for disinfection was also in shortage at the beginning of the pandemic. Not only the government-owned Taiwan Tobacco and Liquor Company shift their production lines to rubbing alcohol, the other 9 private-owned brewers also joined the national team. Then people can get the rationed alcohol at the contract pharmacy stores. As maybe you know, there are more than 13,000 convenience stores in Taiwan. It is the second highest in density in the world, only second to South Korea. During the pandemic, all the convenience stores participate to our COVID-19 constraint effort, and people can get a rationed mask, rubbing alcohol, and a rapid test kit at the nearby convenience stores. Not only pharmacy store and convenience store, many IT programmers also contribute to their talent. For example, around 140 different versions of mask map were created for free use, and people can figure out the remaining quantity of rationed mask at the nearby pharmacy or convenience stores. When the domestic mask need was satisfied, Taiwan donated over 52 million surgical masks to over 80 countries to support their medical personnel in containing the COVID-19. We also collaborate with the United States and the European countries to develop the rapid diagnostic test and the antiviral medication and the vaccines. We are helping each other to contain COVID-19 in the world together. The preparedness and the mobilization of healthcare organizations, as the Dr. Mata mentioned in European countries, I think was the key to pandemic control and the life-saving. Different to some countries, not only public hospitals are required to treat confirmed cases. In Taiwan, all hospitals, primary care clinics, and medical personnel participate to COVID-19 combat, regardless of the government or non-government sectors. Why can Taiwan achieve this goal? I think we just turned the old crisis into our opportunity in 18 years ago. This can be traced back to the SARS outbreak in year 2003. A few private-owned hospitals and primary care clinics closed their door to SARS patients at that time. Therefore, the amended Infection Control Act mandates all the healthcare organizations should prepare to the emerging contagious diseases. The preparedness is to be audited by the healthcare authorities on a regular basis, either by the local health authorities or the Joint Commission of Taiwan. That is the reason why our healthcare system can ready to face the COVID-19 outbreak quickly and efficiently at the first time. According to the government infection control plan, there are 6 medical networks around the country for the emerging contagious disease, such as COVID-19 or the SARS. These networks are composed by 227 public and non-public hospitals, and their preparedness was qualified by third-party accreditation. These networks are the leading by the local command centers, but the overall system was supervised by the CECC. There is only one government-run single health insurance system called the National Health Insurance. Nearly all Taiwanese and legal residents from abroad are mandated to have this health insurance, and every person's medical service information has been uploaded to the cloud system. And maybe this day we run faster than the European countries. We always adopt the digital health earlier in the previous few years. Since the beginning of the pandemic, personal health records were linked to their immigration record. So as a result, at the point of the medical service, physicians can track back the travel history of patients abroad and with patients approved. This was very important for reducing the risk of hospital transmission. And all confirmed cases, including those from the other countries without Taiwan's health insurance, can be treated by our advanced medical technologies at zero cost, because the National Health Insurance and our Taiwan CDC will pay the bill. My conclusions are, Taiwan has proved its resilience. We talk a lot about resilience. I think Taiwan will have proved our resilience through our strong public and private collaboration in times of pandemic. And both the government and non-government health organizations were united to combat the pandemic and save lives. The COVID-19 pandemic has been up and down for the past 3 years. When its mortality rate is lower than our expectation, which means that we need to live longer with the COVID and its variant, and because of low mortality rate, the pandemic is not over, and we need a stronger global solidarity and more comprehensive international collaboration than the status quo. Thank you.
Thank you so much to Professor Wei-Chang Lee. Would you please remain on the stage and join us for the QA? Thank you so much. All right, thank you so much to all of our speakers in this session, Professor Lee, and also Mr. Lamana, Dr. De La Mata, and also Professor Borish. And now we're going to have a 15-minute QA. So if you have any questions, you can raise your hand later. And before asking questions, please let us know who you are and which speaker you want to direct your question to. And people online, you're also more than welcome to leave your questions or comments online. Thank you so much. All right, now we'd like to bring our speakers back to the stage. Our moderator, Professor Chen, our speakers here with us in the room, Professor Borish and also Professor Lee. And we also have 2 speakers joining us online. We have Mr. Joseph Lamana and also Dr. Isabel De La Mata. And here, before we begin, just want to express our special thank you to Mr. Joseph Lamana. Joseph, it's 4 o'clock there, right? Yeah, on the East Coast of America. So everybody, let's give Joseph a big round of applause. Thank you so much for staying with us and so early in the morning. All right, over to our moderator, Professor Chen.
Okay, thank you for Joseph and Isabel, especially for the Joseph. Are you still awake? Thank you again. And so now I think we have the 4 speakers. They give the very excellent talks about the crisis or the COVID-19 pandemic, how to deal with that, and also from the different country view, different the area. So finally come back to the Taiwan. The Dr. Lee shared the Taiwan experience. So now we'd like to ask a question. Yes, the lady there.
Yes, please use the mic.
Thank you. My name is Liz Nkosi from the Kingdom of Eswatini, Minister for Health. I just want to appreciate the work that Taiwan has done in the pandemic, particularly
you probably have to speak
particularly
closer to the mic,
taking
please.
leadership in terms of response planning and all that. From the Kingdom of Eswatini, we had quite a lot of support from Taiwan. I think by March, we're able to get support from medical experts from this country to just help us set up our ICUs and response teams. But the amount of PPE that we got, not only did we get PPE, medical equipment support from here, but eventually people are looking at what you were presenting last about the production of facial masks. Eventually, Taiwan sent 2 of those production lines to Eswatini so that we're able to produce our own. So I really am just appreciating the efficiency and just the sheer amount of global support that Taiwan did during the pandemic. Thank you.
Dr. Lee, do you want to give some response?
Thank you. I think actually it's a government policy. Once we can satisfy our domestic need, we want to help and we help each other. And so actually during the SARS outbreak, Taiwan also received many care from the other country. If I trace back longer, in about year 14 or 15, Taiwan was in the developing stage. Actually, we received a lot of assistance from United States and the other developed countries. So it's time to feedback, and we are honored to do so. Thank you.
Okay.
Hello, it's Fran Baum asking a question. Martin McKee on day 1 showed us the considerable global inequities in access to vaccines, really dramatic inequities. I just wonder how, I don't know, either from Europe or the US, or how in the future we can avoid that, how we can really be a global community and ensure that those vaccine rates are the same across the world. Because we had COVAX, but as Martin explained, COVAX didn't work, it failed. So, you know, what part of pandemic preparedness can we do in the future to make sure that the world is much more equal, whereas what's happened in this pandemic is it has become more unequal, both within countries and between countries.
Joseph, do you want to say something about the vaccination?
Yeah, thank you for the question. I don't have a good answer, unfortunately. You know, unfortunately, I almost hate to say, but there are political overtones that drive a lot of the decisions, at least in Washington. And so it's going to be, hopefully we all come together and in forums like this, we can talk about our shortfalls and our needs and have the ability to, as I mentioned in my discussion, not exchange cards during the crisis, but to actually have those relationships already pre-established so that it becomes easier to have these conversations. I think that was part of the challenge was, who do you talk to when you need help? And we found that to be you know, a challenge on our end. We were getting requests from multiple nations asking for help, and we had difficulty even in our own government trying to figure out where those requests should land. So I think we've learned a lot in that. I think we got better as the pandemic went along. We were sharing more and more of the vaccine stocks that at least we had available. But it took us a while to get to that point, and I certainly agree that we need to get there quicker at the onset. So that's a lesson learned for us, and hopefully that's something we can improve upon in the next outbreak.
Dr. Lee.
Of course, there are some people, they don't want to wear a mask. But I think it's very important, the public awareness, as I mentioned earlier, but I don't have time to elaborate more. Because the mask is to protect ourselves, right? We call this the public health intervention. It's very important, but it's also, I need to mention, like, it's also part of our culture. When anyone in Taiwan, he or she was sick, and she will be she or she need to wear a mask to avoid transmit the disease to the others. So we will feel very comfortable to wear a mask, and we will feel comfortable to see the others wearing mask. I think that's the difference between Taiwan and many other countries. In terms of the vaccination, it's a huge problem. As a clinical doctor, I always persuade my patient to receive vaccination, but I cannot guarantee the safety because there are some unexpected side effects from the vaccine, especially for the different kind of vaccines. They didn't receive a long-term study before, like the other vaccine, because for the life-saving. But you can see, but the CDC and the CDC, they continue to track the side effect, especially for the severe side effect, and to let the people know that there are some certain risks. But in conclusion, is that the benefit is much higher than the risk for vaccine saving. So in Taiwan, you can see the overall vaccination rate is pretty high. I think it's on top 5 of the world, but it's not the highest. But for some people, especially the elders, they're still reluctant to receive the vaccine because of they heard some tragedy stories and after the vaccination. So we just let them know, if you cannot or don't willing to receive the vaccine, please stay at home and try to avoid contact your friend or even relatives. And that's the way to protect yourself and also protect others.
May I? Thank you that I let you go first because I wanted to know if my impression is right. I come from Switzerland, which is a classical anti-vaxxer country. We have strong anti-vax movements already pre-COVID. We are the country that is exporting measles regularly to other countries because more and more children do not have a measles vaccination due to their parents considering that this is bad for their children. And on the basis of this tradition, the introduction of the COVID vaccine was very interesting. First of all, the population said, you're going to kill us because we don't have enough vaccines. Switzerland was a little bit late in buying and getting access to vaccines. So the population said, you're going to kill us because we don't have access to vaccines, whereas our European other countries do have. And when there was enough vaccine, they claimed that you're going to kill us with the vaccination. So you see that it is a typical point where I think both, as you mentioned, the attitudes and the cultural, if I may say so, attitudes are important. In the German-speaking part of Switzerland, health is considered a very private issue, a very personal issue. So vaccination and vaccination programs, screening programs, come from the state, and the state should not interfere with your health. So that's one of the things. If it comes to mask wearing, I come here to Taiwan and I see people wearing masks without having a personal attitude as this is against my personal freedom. Nobody started to explain me that this is against your personal freedom. And you explained it to us again. Whereas recently I had to cross a border and le douanier, the man at the control, said, are you wearing this mask free of will? And I said, oh, this is my public health moment. And I said, yes, free of will, because first of all, I know, I come from public health, that mask can be good against general flu, COVID, whatever. And in addition, I said, you know, if I go to take a plane, a lot of people now have COVID, don't test, don't want to know, and go into planes without masks. So my chances to win in the lottery or to get COVID on a plane where at least 5 will stay with me for 6 hours in a plane is quite high, much higher than winning in the lottery. And I saw that in the person's mind there was something like, ah, yes, I see. That I say this long story because I think it's important how we communicate. And we haven't done a good job in at least the European countries that I know, Switzerland included, about masking, about public health measures. And in addition, we have this problem of personal freedom, which is mixed into all questions of vaccination, mask wearing, all public health measures. So I think there is a difference between our areas of the world, but there is also a defect, at least in my place in Switzerland, of a good communication and the way to explain our measures.
Okay, thank you. Isabel, do you want to say something?
Yes, thank you. Regarding the mask and the vaccines, the attitudes of the European Union member states have been quite different, and the responses of the citizens too. For masks, most of them took legal approach. So people were obliged to wear the mask in certain place, and they were not allowed to enter those places, or they received amendments from the police if they were not wearing the mask in all these places. The consequence also is that, not necessarily the consequence, but the situation is that once that the enforcement was finished and was not anymore compulsory to wear masks in the planes, for example, or in the public transport, almost everybody stopped to wearing the mask. And very few citizens are still, because of individual decision, because of public health approach, wearing the mask. And this is not good. For the vaccines, where nobody could oblige, I mean, it's not possible to oblige to vaccinate, and that we were making at the individual member state, but also at European level, campaigns, but everybody was willing to have the vaccine, or the population that were at the beginning offered the vaccination. So, and here we see that the elderly population, contrary to what was said before, the elderly in many countries are almost all of them are vaccinated. It's different for the young people. One tool that helped in having this vaccination, apart from the campaigns and apart from the real conviction that the vaccines were working and that was something to have, was the COVID certificate. So you cannot enter this place, you cannot travel if you are not vaccinated, if you don't, cannot show the COVID certificate. I mean, it's not really it's not really an educational measure, because it's more like a compulsory, but supported in having people vaccinated. We are finding more resistance with the booster. So we had at the end 70% of coverage in vaccination for the first 2 doses, but for the booster is not so easy. And also we saw huge difference among member states, especially in the east and in the west of the European Union. And another bad effect of this pandemic, we have just finalized the confidence report on vaccination for all the vaccines in the European Union in general, and the confidence has decreased in vaccines in general. So we don't know exactly why, but is the confidence was going a little bit up from 2019 to 2020, and now is down. Is down again for almost all the vaccines, and especially in the youngest population. Still okay for the elderly one, but not good in the rest. And I also wanted to react to for how we can be more equal in the access for vaccination. The COVAX didn't work as we wanted. It worked. the donation of vaccines didn't work as we thought it was going to do. And one of the things that I think we have learned is that what we need is to support the health systems in the low and middle income countries, the health system in general, and not just the vaccination services. And also the European Union now is contributing to be able, that some of those countries are able to produce themselves the vaccines, and there has been this support program that are going on and well still supporting the global efforts in general. Thank you.
Thank you. So, yes, last question.
I don't mind going last. My name's Jack Niedenthal. I'm the Secretary of Health from the Marshall Islands. I first want to thank Mr. Lamana from ASPR. Maybe I think it's really important for people to understand. First of all, I should preface anything I say about the United States. That's where I was born. I grew up there. But I spent the last 33 years of my life hammering the United States on behalf of the people of Bikini Atoll because their islands were used for 67 nuclear tests. So when I compliment the United States, it's not the easiest thing in the world for me to do. ASPR and the CDC and the US government, we were vaccinating people in December of 2020. They got us those vaccines so fast. They got us the testing ability in April of 2020. I'm sorry, April of 2020. So they got us that really quick. A lot of information was given to us. And when we had our outbreak in August of 2022, this year, we went 2.5 years without COVID. We went all of calendar year 2021 without even a single border case. Maybe some of the larger countries of the world might want to ask how that happened. We also have, for people over 18, we were 98% vaccinated. You might want to ask about that too. But ASPR, during our breakout, they sent out John Bartlett, and he made sure we got 8,000 doses of Paxlovid because we had convinced our people that the therapeutics was the way to go. And because of that, we only had a 0.11% fatality rate. And I also want to deeply compliment the government of Taiwan. They were so proactive in always helping us from time to time, getting PPEs and everything while we had the borders closed. A lot of countries really hesitated to help because they didn't want to go through our quarantine procedures that at times was 5 weeks long, if you can imagine that. But we kept the COVID out. And I also really want to emphasize, I know Bettina was talking about this universal sort of response that we should come up with. Please understand that one size doesn't fit all. Oftentimes small island states like the Marshall Islands or Tuvalu or Nauru or Palau that are here today, one size doesn't fit all for us. I can't tell you how many battles we fought with worldwide health organizations like WHO telling us that border closures don't work. And we kept saying we're going to do it anyway. We were the first country to do that. And it came with a lot of distress to our people. They thought it was the wrong thing to do, and I was really a big pariah because I signed that thing. But within a couple of weeks, it was a different attitude altogether. They realized what was going on in the world and how scary that disease was for us with high diabetes rates in our country, one of the highest per capita in the world. So the idea that when the world starts coming up with these worldwide response plans, they have to keep in mind these smaller countries and some of the things we face because we don't have resources that the other countries do, especially health resources. And oftentimes, I know you were mentioning women and championing women. I think when you're a leader in healthcare, one of the most important things you can do is always defer to the expertise. And for me, I don't care if it's a man, woman, or a Martian. You have to put the best people in the right places. And in a small island state, sometimes you just have to rely on those around you, and sometimes they're people from all walks of life and different nationalities. So once again, I really want to thank the presentations that you did, very thoughtful, and I really appreciate again everything Taiwan's done for our country in the Marshall Islands. Kamal, thank you very much.
Okay, thank you. I saw that still the same question from the online the system, but I think because the time constraint, so we would like to thank you all the 4 excellent speakers and also the audience to join this section. Thank you again, and thank you, and I wish you the happy and healthy. Thank you again.
Thank you so much to our moderator and all the speakers. Especially we thank Dr. De La Mata and Mr. Lamana. Please give yourself some sleep, okay? Thank you so much. Thank you. All right. You may return to your seats. Thank you so much. 谢谢我们论坛非常精彩的这个讲师哦。And lastly, ladies and gentlemen, the forum is coming to an end, and to give us the closing remark, ladies and gentlemen, we'd like to hear from the organizer, Ministry of Health and Welfare, once again on some concluding thoughts. Ladies and gentlemen, please join me in welcoming Li Fen Li, Deputy Minister, Ministry of Health and Welfare, Taiwan, to the stage.
Our distinguished guests, ladies and gentlemen, good afternoon. Okay, on behalf of the Ministry of Health and Welfare, I would like to thank our guest speakers, colleagues, and all the participants of the Global Health and Welfare Forum in Taiwan. Thank you for your support, participation, and insightful exchange during the last 2 days. The outbreak of COVID-19 has posed tremendous challenges to our health system and reshape our world in many respects. By coincidence, our event took place following the lifting of border restriction in Taiwan. This hallmark development not only enabled over 43 speakers and government officials from 13 countries to attend physically, it also signified that the pandemic could be finally behind us. Such a time of transition often leads us to reflect on what we have achieved and what could have been done better. As suggested by the theme, One Health, Advancing Health and Well-being for All, we must also seek ways for advancement. In the last 2 days, we are fortunate to hear some of the most inspiring thoughts on how to achieve environmental sustainability, how to effectively prevent disease and deliver health care, and how countries and stakeholders can work together to promote global health and people's well-being. My sincere appreciation for those profound recommendations. I believe they provided much needed food for thought and will have lasting impact on our planet. As the side note, I would also like to extend my earnest appreciation to the Ministry of Foreign Affairs and the various departments and administrations under the Ministry of Health and Welfare. Their outstanding effort has resulted in the success of this event. At this year's forum, we have seen more than 1,000 participants from over 30 countries join us physically and online. They consisted of experts from the public and the private sectors of both local and international regions. We are grateful for their extraordinary contributions and touched by their enthusiastic participation. Lastly, I wish everyone good health and all success in life, and we look forward to seeing you again soon. Thank you very much.
Thank you so much to Deputy Minister Li-Fen Li. Thank you, ladies and gentlemen. Ladies and gentlemen, 2022 Global Health and Welfare Forum has come to an end. We'd like to thank all the speakers for their wonderful talks. We'd also like to thank Health Promotion Administration under the Ministry of Health and Welfare for organizing this annual event. We also have the Director General Zhao Junwu here with us today. Would you please stand up? Thank you so much. Yes, most importantly, we thank you here or online for your participation. Everybody, stay connected with each other, stay safe, and most importantly, stay healthy. We'll see you next year. Bye-bye.提醒有借口译设备的贵宾，请记得离